Hello, everyone. I think we can get started. I hope most people are here. Welcome. This is the plenary session of the WEO CRC Screening Committee meeting aligned to UEG Week in Copenhagen. And Michael Kaminski, the regional chair for Europe, and me, myself, Evelien Dekker, as a global chair, we are very, very happy to be here with you and to see how this committee has really flourishing again, because many people have attended this morning expert working groups sessions. We even expect more people in the afternoon, up to 170 subscribed. You never know how many will end up here, but others did not and are already here. So let's see. But we are very happy to see the number of people, but that's of course not the most important part of it. The most important is the enthusiasm, the intelligence you bring, the energy and the scientific discussions we have, as well as the politics. I think that is the perfect combination we have in this committee, because it's all the different parts that need to bring us further in colorectal screening, cancer screening around the world. So I thank you for attending. I hope you will do for many years. We keep having this crowd. We keep discussing amongst each other on all the different aspects of all the different programs, on the research. And I think the discussions is one of the best parts we have. We always lack time for discussion, so that's always a problem. And every time we say we should have more time for discussion in the sessions, we usually don't exceed, because people are also very enthusiastic in giving their talks. But at least there is a lot of time also with coffee, with lunch, and make sure you will be with us also for the drinks. I just heard from Aljana and Ruth that also the venue for the drinks is fantastic. So please stay after the session to enjoy that as well. So again, this is the UEG meeting. We've been busy recently. We are constantly trying to design nice programs for meetings. I've been in South America last week for the South American GI meeting, where we had a WEO CRC screening session. We will be going to the Asian Pacific meeting in Bangkok. And then next year, of course, there's again ESGE days and then DDW. And then also the ENDO 2024 meeting. So many meetings coming up where in all those meetings, our committee is being represented with programs. So very happy to have that opportunity. Thanks again to my regional chair, who will in a moment explain the program, but also to the expert working group chairs, because I think we had an excellent morning with 5 different sessions. The FIT screening is usually very active and has a lot of attendance. It was actually in the biggest part of this room and didn't really look like a working group, I said, because it was so big. It was fantastic. The other groups did fantastic as well. I'm really happy for the work the working groups are doing. Actually, there's manuscript being produced, there's new research starting, there's political efforts. So thanks again also to all the working group chairs. Besides that, of course, I'm very much indebted to the sponsors. We will have slides showing them all, but I think it's fantastic to have them on board, especially because it means that we can offer you this program without charging you any costs. And that means that I hope as many people can participate as they like. They still have to travel and pay for that. That's why we like for the plenary session, we are also recording it and are putting it on YouTube. So in the end, I hope for anybody interested in CRC screening, it will be possible to attend this session as well. Last but not least, I will do that at the end again, but I will do it already now. Many thanks to Aljana, who did a great work, a lot of work to try to pull all those doctors and handing in their talks and making all the sessions work. So she did a fantastic job, and of course, as always, Ruth as well. So thanks very much. Yeah, already. It's early. Maybe later again we will upload for you. Maybe. So let's give the word to Michael about the program.
Yeah, so just a few words from myself. So welcome again on my behalf as well. I want to thank you all for sending your suggestions for the plenary session, because this is how we want to create the program. So we get your suggestions, we try to pick up the hottest topics, and we try to design the program which will fit your needs, fit your interest, and it will make our interaction really, really good. So what we are having today, we have 4 sessions. The first one is on insights from ongoing colorectal cancer screening programs. Already most countries have introduced programs, so we want to hear back how it is rolling in different countries around the world. Then we will move to the management of screen-detected lesions. It is much more toward the treatment part, but this is what we, I think, discovered with screening. So once the screening is established, we are facing another problem: what to do, how to treat these patients, and how to diagnose them better. So this is the second session, which is I think will be really, really exciting. Then we have also something about novel colorectal cancer screening tests. So again, some excitement, what will come in the future. And the final session on quality in colorectal cancer screening. And the final session, the fifth one, will be the social session.
Yes.
So, okay. So,
political session.
Yeah. So thank you all for coming, and I would like to invite our moderators or chairs, Linda Rabenek and Jaroslav Regula, to moderate this first session. Thank you so much.
Thank you very much. I feel very honored to chair this first session together with Linda Rabenek from Canada, a well-known expert on screening. My name is Jaroslav Regula from Poland. This session is about ongoing or starting screening programs. And I have a great pleasure to introduce and ask to present the planning the implementation of colorectal cancer screening in Latvia, Professor Marcis Leja from Riga. Marcis, the floor is yours.
Thank you. Good afternoon. And yes, as Evelien mentioned, the meeting is flourishing, and usually the speaker is expected to demonstrate a perfect success story, but I have to say that this will not be the case. And actually, I was not the one who was suggesting the topic. That is, everything goes to Carlos Enore, who was requesting me to speak on where we are. But yeah. Let's go ahead, and I hope that I'm able to switch the slides. Yes, I'm briefly going to touch really the history of how the screening was introduced in Latvia, what is the current situation, and actually what perspective we do have. And I'm going to start and end with some citations from our co-chairs. Sorry, it will not be Jaroslav, it will be Linda, who has been repeatedly demonstrating that building up a screening system is not easier than building an airport. And we know very well from the other speakers that it should take at least 10 years. I should say that also sometimes 10 years is not enough to build this. And that is actually the key slide, what I wanted to demonstrate from our program in Latvia. As all of us, we know that the European Council recommendation back in 2003, of course that has been renewed the last year, was setting the stage for 3 cancer screenings, colorectal cancer being one of them. And that has been really the background why really the screening efforts have been introduced to our country as well. Not because really the ministry felt the need to start the system, but because the European Commission was requesting to do this. And apparently unfortunately, the results were not very perfect at this stage. So a few years later, in 2009, the program was called Organized Cancer Screening Program with no changes to the organization, unless really the positive and negative test results got reported. So that was really the only change there. But actually, when starting those efforts, we took the experience, and definitely we were looking out in the European experience. And that time, the Czech experience seemed to be really the best. Going out through GPs, having really GPs supported for really either delivering or reading the test. Unfortunately, this did not work in Latvia, and I suppose it's not also perfect in Czech Republic, but I'm not going to comment on Czech Republic. A few years later, we were performing a pilot study, and with mail-delivered tests, comparing different tests, but actually the results of the pilot study were left remaining in the ministry on a shelf. Similarly to the expert group recommendations in 2012. And the last change what we do have is really fit test introduction a few years ago, and that has really provided certain benefit, but not too much. But anyhow, the program so far has gone through GPs, and if we are looking at the results are really not very favorable. But if we may listen the ministry people speaking and how they could position this, we have really 3 times increased the coverage, but that is 50% of the absolutely minimal required coverage. That is really the hard reality there. So definitely we need to do something more, and we need to change it, and how this could be potentially done, I'll come back later. But before then, just our experience when delivering the program through GPs. First of all, it is very variable, and there are GPs that are really very motivated and doing a great job. There are other GPs that don't want to hear at all about the program, and definitely we are resulting of severe inequalities between those populations, because there's another way to have a test done. Then definitely, and that's all we know, that only a minor proportion of the citizens are attending the GP on a regular basis, and definitely the quality issues. And that is what we recognize. First of all, reading the tests, and in the case if a person sees a positive test once in several months, it is very hard really to read, and it could be either under or over diagnosis, and that is what we recognize in our pilot study as well. But since there are different access timing to the colonoscopy for the GPs, we were absolutely sure that it was some falsification of the results in one way or the other, whether to get reimbursed or to have the patients referred to colonoscopy faster when they were really the colonoscopy was indicated. So indeed, at least in our hands, in our experience, the delivery through GPs at the only approach definitely does not work. This was a study design where we incorporated 2 fit tests, GAIAC tests, and also the invitation, pre-invitation, and reminder letters. I will not go in more detail on this, but and it was conducted already 10 years ago, and already then we demonstrated that actually the fit test delivered by mail, although politicians were not really believing in this, with the reminder letters, but yes, reminder letters were important, were really the tool to reach the minimum participation rate in the program. And even a cost effectiveness analysis was made. I'm not going to go into the details, but it's very well demonstrating the need for the initial investments that are really followed by the gain from the program in the future. So how we see the critical points from our experience for successful program implementation. Once more, I can cite Linda, who is saying that if to put all the photographs of the ministers that have been in force before the screening program has been implemented, so it would be a whole gallery. That could be the case also in our situation, but we have to say that now we are in special situation because we have got a new ministry minister who is gastroenterologist, so maybe that will help. So definitely we have been lacking pragmatic and comprehensive screening implementation plan as well as governance, and we are lacking an IT platform, and I think those are really the big issues to address the quality assurance, and definitely some funding is required really to have this. So far about Latvia, but I will just comment on two other things and our experience on this. First of all, if the decision makers are not listening to the local specialists, then you need to invite really the international experts, and that's what we managed to do, and we are really grateful, and that seriously that was really of help that Iris Lansdorf-Vogeler has been involved in this, and there are instruments, and that is what I wanted to communicate. Please use those instruments in the European countries. They are called technical support instruments that you can use to have experts from expert countries, at least to have them available, to make them available to the widening countries. We have been doing this, and actually we had a meeting at the ministry a couple of days ago, and now really it is helpful. The project has been done either in Latvia or in Slovakia. And to finish, there is another activity that is planned for Europe. It is called Joint Action. It will be covering all the different types of screening, not only colorectal cancer, but colorectal cancer is definitely in. And since we are involved in this project and all of the EU countries are involved, I would encourage really to use the benefit of this. First of all, the countries will be asked to share the data according to United Standard to the ECIS platform. ECIS stands for European Cancer Information System, and Italy has been really, and Carlos Senore has been intensively involved in developing those standards. So, but I believe when the countries will be asked to share this information, they will really recognize of how much data are they lacking to be shared. So then Austria has been initiating meetings on the best practice exchange, so let's see how it will working out. And Yaroslav should be responsible for the training course and audit that should be made available for all the European countries. Furthermore, Erasmus MC will be involved with cost effectiveness modeling, and Italy will be guiding the efforts related to personalized screening, in particular related to colorectal cancer. So I would suggest that we all should use what is available here, and with this I would like to thank for the attention.
Thanks. Thank you very much. We are going to invite our speakers up at the end to join us for the questions. Thank you, Marcis. We're going to go on to our second talk, and Dr. Mircea Manuk from Bucharest, is going to present on the colorectal cancer screening pilot there in Romania.
Hello, everybody. First of all, I would like to thank the organizers for inviting me to give some impressions regarding colorectal cancer screening pilot in Romania. Therefore, the agenda has to show you where we started, how we do it, where are at this moment. And it is very easy to say how we started, because in 2017, when this report appeared at the European Union, at the Commission, Romania was among the three black sheep of EU, having nothing at that time, so very easy to say how we started. After that, we started, of course, with technical assistance from structural reform support, and I'm pleased to say that experts here, like Evelien, Dekker, Mikhail Kaminski, Carlos Senero was the chief of the experts who provide us technical assistance in order to develop our methodology of screening. It seems that we choose wise, and I will show you how it happens. So we consider how to develop our pilot projects, a two-step project. ROCAS 1, which was in charge with the framework for the screening, therefore we provide the national methodology. the National Screening Register, the training for all the people involved in the screening, and of course the information education campaign. And after that, on the second step, we have 4 regional pilots, 50,000 persons in each region, therefore 4 regions, 200,000 persons. So the partners for OCAS 1 was the National Institute of Public Health, and Carmen Ungurean is here with us. He co-managed with Professor Gheorghe, also here from Fundeni Clinical Institute, this large project. We have in this, let's say, personalized methodology, we have some innovations, like GPs were used as central pieces involved in the screening, and this was somehow despite the recommendation of our experts from the EU who said the GPs might not work, but for Romania it was really impossible without GPs. And of course, we introduced a risk questionnaire in the screening flags prior to the FIT provided, because we had no data regarding familial cancer and personal history, familial history, and so on. And of course, we developed the register together with an endoscopic and pathologic report, standardized report, therefore generating standardized results regarding these investigations. Of course, we had many barriers. For example, we have to complain with EU funding, because these projects were provided with EU funding, so not national funding. Therefore, 50% of population screened has to came from vulnerable groups, which is, of course, difficult to reach target. And of course, COVID cut us half of the time for this pilot project, so we have to move fast. These are only very small framework for the screening register, which was developed in this project. And here is the results of the training. We trained 850 doctors, of course, majority of them GPs, and we have the campaign, and here are us doing training. We try many schemes because it was difficult to do, particularly during the pandemic. So we have on-site, online, hybrid, whatever we can do, we just did it. Therefore, here you see the 4 regions which develop this regional pilot screening, and the 4 institutions who are in charge with the management of these projects. And here are results, the 4 slides for the 4 regions. I just want to stress out that South Muntenia, which was coordinated by Fundeni Clinical Institute, and Professor Gheorghe is the manager of the project, because they will end in December 2023, so not very far away. And Southwest already finished the enrollment of 50,000 persons screened. And of course, Bucharest Ilfov around 40,000, and Southeast around 30,000. I will show you aggregate data we have from the National Register. And you see we use a cutoff of 20 milligram per kilogram for both tests. And we have the participation rate, so return rate of FIT, almost 90%, which was really astonishing even for us, because we do not expect such a large return rate, because as I told you, more than 50% is vulnerable population, so difficult to reach them. And despite that, we have a very good return rate with a positivity around 5.4. Therefore, we do not change the cutoff for the moment. We consider it is very much okay, between 5 and 6. And participation at the colonoscopy, it's more than 50%. It's less than we expected. We still have 2 months in order to increase this figure, but is surely the indicator we consider is not the one we expected in this project. Regarding the results, the quality indicators for colonoscopy, I will show only the region South Muntenia, because these are clearly evaluated, double-checked, so validated from the expert point of view. And of course, here are the data related to colonoscopy. You see the percentages of adequate bowel preparation, cecal intubation rate, complication rate, no perforation, 15 bleedings after therapeutic colonoscopies, and appropriate polypectomy technique and polyp retrieval rate close, a little bit higher or lower to the levels accepted as being adequate for a good quality program in screening. Here are the results from pathological point of view, and it's important to stress out that more than 50% of FIT positives had adenomas, and more than 10% of FIT positives had carcinomas. And of course, higher percentage in male population, and higher percentage in the group less than 65. Of course, in carcinomas, higher group over 65 years old. So screening looks very much okay in this group in order to find a large number of lesions. Of course, rated lesions are found in, and the percentage are presented there. I think also very important to see this slide. You see 1,200 and so on adenomas found and resected, and this 5% high-grade dysplasia between these resected lesions. And we have also serrated polyps resected, and what is really important is that within adenocarcinoma group, we have 23 out of 99 cancers. We have PT1, and 16 out of these 23 were considered as completely solved after polypectomy. Here are also the numbers of no lesions. So around 20% of FIT positive has no lesions, and the number of polyps which were not retrieved, so we do not have pathological result. At the end, we can say that this project validates that GPs, if they are interested and well-trained, might represent a good provider for the screening and for the FIT test, at least in vulnerable groups which we cannot attend, and maybe even you cannot attend in your country very, very easy. The ROCAS screening national register is an important tool not only to provide databases, but also to provide the quality indicators, because all those quality indicators can be extracted from this register, because this standardized endoscopic and pathologic report. Almost all quality indicators were fulfilled for FIT testing and also for colonoscopy, and a large number of lesions were discovered, and the cancers were in earlier stage. At least 23.2% were PT1, which is not very often seen in diagnostic colonoscopies, at least in our country. And ROCAS projects represent the first step of the national screening program. And we already started to develop the new projects, which will be double funded by EU funding for vulnerable population and national funding for non-vulnerable population. And we will have 8 regional projects from the year on. And of course, we will go to national screening, and we expect, I think that within 10 years, we can do the rollout if you are lucky. And of course, thank you very much for listening to us.
Thank you very much. Splendid participation rate, I must say. We have to ask you about that. But before we do, we're going to hear from Dr. Jannie Dressler from University of Copenhagen. the effects of the Danish colorectal cancer screening program on treatments, hospitalizations, and healthcare costs.
Okay, I just need to be sure how this works. It's that one under pressure? You know that?
Forward.
This one, okay.
Yeah.
Thank you very much, sorry. Yeah, so I'll present for you the results of 2 of my studies from my PhD, which was focusing on the more long-term treatment consequences of the screening program and the healthcare costs. So I have no conflicts of interest. So first I'll give you a little bit of background to put the setting of the Danish colorectal cancer screening program. So the implementation started in 2014 to 18, and it took 4 years because the lack of colonoscopy capacity. So those 4 years hence represented the prevalence round. So all Danes aged 50 to 74 years are invited to participate in the screening. They receive an invitation by mail, and they get a stool sample kit enclosed in that. So when the sample is collected, it's sent by mail to the laboratory that conducts a fit test, and the cutoff value in Denmark is also 20 micrograms hemoglobin per gram of feces. If the fit test is positive, they're sent to colonoscopy, obviously. So the participation rates in Denmark are 60%. Of these, 5% has a positive fit, and the colonoscopy compliance is more or less 90%. Of these, 4% are diagnosed with colorectal cancer, and 56 has at least one adenoma. So these studies that I'm presenting for you today, they focused on the 4% who got colorectal cancer. And the aim of the study was to investigate the differences in treatments and healthcare costs between patients with screen-detected and non-screen-detected colorectal cancer during the first screening round in Denmark. And our hypothesis was that screening generally reduces the requirements of treatment and also the healthcare costs. So before I move on to the studies, I want to present you for 2 hypothetical patients. Patient Hansen, the green guy over there, he was diagnosed with colorectal cancer, and he was diagnosed because of the screening program. Patient Peterson over here, the red guy, he was diagnosed with colorectal cancer, but not because of the screening program. We'll get back to these guys later. So, both of the studies were nationwide, retrospective, register-based cohort studies. They followed up 2 years after diagnosis, and the population was Danish residents aged 50 to 75 years, diagnosed with colorectal cancer between January 1st, 2014, and March 31st, 2018. So we censored all patients dying or immigrated in the period, and the outcomes were treatment, duration of hospitalization, and healthcare costs 2 years after diagnosis. The treatment included contacts to the primary sector, emergency surgery, metastasectomies, visits in oncological outpatient clinic, and treatments with chemo or radiotherapy. The total costs included all hospitalizations, costs in the primary sector, and out-of-hospital medication costs. And we used a lot of different models. We adjusted for sex, age, child's and comorbidity index, and type of cancer in order to reduce healthy user bias. We stratified into USCC stages where possible, and excluded interval and post-colonoscopy colorectal cancer in order to reduce Lang's bias. So before I start introducing you to this table, we did not do any comparative analysis on our background demographics because we already know that these 2 populations are very different. I will just show them to you in order to present in which ways they differ. As you can see, the populations were rather big. There was more than 4,000 patients with screen-detected colorectal cancer and more than 7,000 patients with non-screen-detected colorectal cancers. So, patients with screen-detected colorectal cancer were generally more often in the oldest age group. They were less often having a child's and comorbidity index of 3 and above. They were less often active smokers, and they more often had a moderate alcohol consumption. They were more often obese and overweight, and unsurprisingly, they were more often diagnosed with UICC stage 1 cancers and less often with UICC stage 4. They more often had colonic cancer and less often has rectal cancer. So patient Hansen seems to be older, have a lower Charlson Comorbidity Index score, less often an active smoker, more often overweight, and more likely to have UICC stage 1 cancer and colonic cancer. So let's go to the core results. Patients with screen-detected colorectal cancer had a significantly lower duration of hospitalization. Because of the way we did the analysis, I don't have a weighted mean difference, but I have a difference that was not weighted of 22 days. There was no difference in the rates of primary healthcare contacts. And unsurprisingly, patients with screen-detected colorectal cancer had a lower rate of emergency surgeries. That was both the one who had only one and the one that had more than one during the 2-year period. There was no significant difference in the rates of metastasectomies, but patients with screen-detected colorectal cancer had significantly fewer visits in the oncological outpatient clinics. They had significantly fewer chemotherapy administrations and half as many radiotherapy treatments. So, I mean, this could be explained by that they have a lower UICC stage, right? So we did a UICC stratified analysis. And actually our findings were, this is for the oncological outcomes because I didn't have time to present all of them. But it was consistent throughout all UICC stages, except for UICC stage 4, where patients with screen-detected colorectal cancer actually had a significantly higher rate of chemotherapy administrations. So, patient Hansen is hospitalized less the first 2 years after diagnosis. He has a lower risk of acute surgeries, he has a lower risk of visiting the oncological outpatient clinic, and a lower risk of chemo and radiotherapy. So I'll move on to the health economic part, and for a clinician like me, this is a little bit more hairy, so I'll try to explain it in an understandable manner. So this graph I'll explain the graph to you because otherwise it doesn't make sense. On the y-axis, you have the total mean quarterly cost in euros. On the x-axis, you have time in relation to diagnosis, which is represented by 0. So, for instance, 2 means 2 quarters after the diagnosis, 6 months after the diagnosis. And as you can see, there's also minus time, because using this methodology, you need to look 2 years prior to the event to hear the date of diagnosis. So what this kind of analysis does, it looks at the difference prior to the exposure, here the date of diagnosis, and subtracts it from the difference after the event, here the date of diagnosis. And then you get the added difference. Here we did not find any statistical difference prior to the diagnosis, so in order to ease communication, I'll just talk about cost difference. So patients with screen-detected colorectal cancer had 2,393 euros less of healthcare cost per quarter per patient when compared to patients with non-screen-detected colorectal cancer. We did adjusted analysis, but it didn't make a big difference, so I won't get more into that. The main driver of the cost was, unsurprisingly, hospital costs. And when we looked at it over time, we found that the biggest difference was the first 6 months after the diagnosis, where the patient with screen-detected colorectal cancer had 3,911 euros less of healthcare costs per quarter per patient compared to patients with screen-detected colorectal cancer. After that, they were a bit lower. When you look at it over time, you can also see that the biggest difference was found around 1, which is the first 3 months after the diagnosis, which is also where the main treatment usually is done. So that makes sense. Again, we did a UICC stratified analysis and did not find any differences between the two populations with UICC stage 1. In UICC stage 2, patients with screen-detected colorectal cancer had 405 euros less healthcare cost per quarter per patient compared to patients with non-screen-detected colorectal cancer. That number for UICC stage 3 was 688, and for UICC stage 4 was 2,360, sorry. So, patient Hansen has 2,393 euros less of healthcare cost per quarter the first 2 years after diagnosis. That accrues to more than 16,600 euros over 2 years. It also looks as if the cost difference increases with increasing UICC stages. So in conclusion, it looks as if the long-term burden for both patients with colorectal cancer and the healthcare system, as expressed by the need of hospitalization, emergency surgery, and oncological treatment, and per patient quarterly healthcare costs are less pronounced for patients diagnosed because of screening. This is the funding, and thank you for your attention.
Okay, these presentations are open for questions. The microphones are over there in the middle rows. So please ask the questions.
Maybe I'll just ask a quick question. Quick question, Dr. Manouk. How did you ever achieve such a high participation rate of like 90%?
Now it works? Okay. It is astonishing for us. The problem is that the GPs has to perform the risk questionnaire and after that provide the fit. So therefore, people are talking with the GPs. So if they accept to do the risk questionnaires, somehow they are already involved in the pace of in the flux of the screening. And you have to think that, of course, we provide the test exactly how it's provided everywhere, like having the paper for the toilet, and think that vulnerable people from rural areas, they don't even have this kind of thing. So sometimes it was difficult for me to ask the doctor how they do it. We are astonished, but this shows that if the GP really want to participate in this kind of activities, this might work. And it is also an interesting thing that being for free, and of course people not that used to have something for free coming from nowhere, I don't know how to explain it. People who want to do it, they really did it at the end.
Yeah, so I have a, can you hear me? Yeah. So I have a question to Gianni. So I'm wondering whether you have some special pathways for patients who are diagnosed with colorectal cancer screening within your screening program, because sometimes some countries have this kind of a solution which facilitates the flow of the patient throughout the system and throughout the treatment. So do you have something which is separate from, let's say, regular treatment when the diagnosis is done for symptomatic patients?
So after the diagnosis, you mean?
Yes.
No, after the diagnosis, the pathway is the same. We have a political decided, very fixed pathway of how it's done. So it's and a time limit. So it's very standardized.
So it's uniform.
Yeah.
Okay.
Yeah. After the diagnosis.
Okay.
I would like to.
Microphone.
I would like to stress out another important idea from my point of view, and Carmen is here also, and Professor Gheorghe, and they could even say more about that. We had NGOs involved in the process. So they are in charge with information education campaign, but not only, they did some focus groups with population in rural area. So somehow they prepare the patient for the screening also. And we intend to keep this for vulnerable populations, to have NGOs specifically involved in these activities.
Thank you. I have a question for Marcis. There we go. You mentioned all the multiple steps that are you have to line up, get all the ducks in a row, funding, the ministry, and IT system, all these pieces. And what would you say is the most challenging of those, Marcis, in terms of where you are now and to get you over this hump there in Latvia?
Oh, hope it's working, yes. Really, congratulations with the results in Romania, but I don't think, at least in our country and in many other countries, that the single approach through GPs would work. The problem, however, is, and that is a challenge, if to address this, that in the case if part of the GPs is involved, so that would definitely cause very unsatisfaction to those GPs that are involved if starting to mail invitations directly. So I think currently, likewise, I think you have been also reporting similarly in Canada, to combine probably the GP involvement to the direct mailings, that definitely should be the case. But generally the main challenge, I think, is the IT platform to enable really demonstrating the quality indicators. But to our consideration, this would take time to have it introduced, and we still need to improve the situation faster than we do have a functioning system in place.
Yeah, I have a question to Marcis and Professor Manoj. These are the two countries that, in fact, are introducing the screening program. And from our experience and many other, we know that introducing screening is a driving force for improving quality overall of endoscopy, of colonoscopy. Have you, at the start of implementation, looked at the quality of the, let's say, regular endoscopies? Because it would be interesting if it's the hypothesis that screening improves overall the healthcare is true or not.
It's interesting that green is not good and red is good. Usually it's a different color. So anyhow, it is very difficult for me to look backward because we do not have any data. So we cannot compare. But I would like to tell a story which is not a joke, just happened in our unit. As I told you, Fontaine Clinical Institute is in charge with South Montana, and one day we have a special room dedicated in the laboratory of endoscopy for the screening. And in one day, one patient remained a little bit later and was sent to another room. And it was late in the day, and the nurse said, the doctor who was performing the colonoscopy, forgetting that he's from Rocas because it was a different room, he said, oh, okay, just remember the time is finished and the anesthesiologists want to go, so if you can hurry. And the nurse from the Rocas project said, don't talk with the doctor, this came from Rocas, we have enough time to do it. So yes, I think that these things change comportment of doctors and nurses and all the personnel and increase the quality. And moreover, if we have a standardized report in endoscopy and colonoscopy and could provide the quality, the performance of any doctor, it's for sure that if the performance is not good, the doctor will try to increase it. Yes, I really think that this is an important thing, and it's a translation for the screening to non-screening activities as colonoscopy.
Yeah, once more, I would not be so optimistic like in Romania, because actually what we have been trying to convince the ministry and the funding authorities that they are paying for colonoscopy irrespective of the quality. And there are institutions that are measuring quality and that recognize that are increasing the quality, but since the payment is based just on the combination of figures instead of the quality report, definitely that is a case that it's not similarly everywhere. We recognize that this is a problem. My colleague Ivar Stolmans is also in the room, who is dealing with this quite a lot, but we are definitely not there yet. And if my microphone is still green in this case, if you don't mind, I would like to have a question to the presentation from Denmark. So there are really marvelous figures, really, and very exact estimates. And I'm really thinking about whether all of this is coming from your databases and you can really retrieve all those data on exact figures, or still part of this is also assumptions. I mean, for instance, related to treatments and maybe also the cost. Thanks.
Now I think it works. So in Denmark, we're very lucky. We have a very long tradition of registers, and they usually have a very high validity. So actually, we had all these data from registries that have been validated through years. I can add, though, that in the health economic study, we did not include the cost of the screening program because nobody knows exactly how much it costs, which is surprising, I find. We've made very big efforts to try to find it, but because of the way it's administrated, it was simply not possible.
Okay. In Romania, the compliance to colonoscopy after positive FIT is disappointing. It's around 50%. Are you providing sedation for colonoscopy, or are you, let's say, inform the patients about the positivity? I know there are some countries where this compliance is low, but there must be some reasons.
We provide sedation around 90%. So sedation was not a problem. It was per se provided. Only if the patient does not agree with sedation was not provided. The problem is that for the moment we choose only selected laboratories of endoscopy. So distance from the region they are to the screening center, to the laboratory, is somehow big, and we intend to provide within a few years, at least in any county, to have at least one laboratory of endoscopy, which quality parameters acceptable to be included in the screening. And I would like to mention that the NGO has also the quality of transporting the positives to colonoscopy, but only for vulnerable population, not for unvulnerable. So they have to come on their own. So this might be an important thing. And now we are trying to see who came, who did not came, why they did not came. And we observed that maybe some of them did the colonoscopy outside the screening program because it looks much more easy for them. This is good for them, maybe, but not good for the screening program since we do not have data and quality assurance in those colonoscopies performed. So.
May I ask a question to the guy next to me? I'm just very curious because we've been, in Denmark, we've been trying to engage the GPs and it's not going very well because they feel like they have more than enough to do already. So how is the attitude of the GPs towards the screening program in Romania?
They have also already many things to do, but we have discussions taking around, I don't know, maybe even more than 1 year with their representatives in order to understand what are their needs and what they want and how then we can help them. So what I think was the key point in relation with the GP was the fact that the register is very easy to be used. We provide them everything technical, all the devices, so everything is signed electronically everything is provided, the questionnaire is online, is 1 minute, and so on. So within 5 minutes, they solve one patient, so it doesn't seem so much time, and they receive the money for a consultation, which is not that many because it's around, I don't know, €4, so almost nothing. And I'm clearly aware of the fact that not all the GPs will have the same involvement, but we will surely increase the amount of money they will have to receive for these activities. Actually, one of the key points we consider to be in relation with non-coming to colonoscopy, about that question was already raised, is the fact that we consider that they have to be paid another consultation in order to explain to the FIT positive how to take the solution for colonoscopy and how to be prepared and what is important, and it's important to go. So another consultation, which is not on the list, at the end of the guideline was not on the list, so we could not provide the financing for that, and this might be one of the situation.
I know we could go on, but I think we're going to have to wrap up. So please join us in thanking our terrific speakers. Thank you, and invite the next co-chairs up.
Yes, okay. Yeah. Okay. Okay, thank you for inviting me and my co-chair. There's been a little change in the program. It's Jens Axel Nordberg Nielsen from Norway, and I'm Morten Rasmussen from Denmark. I'm colorectal surgeon, and
I'm a consultant gastroenterologist working at. Is it working now?
Red button.
Okay, it's okay now.
No. You have to have a red light around.
One at a time.
So there it is. Thanks. Yeah, Jens Axel Nielsen from Oslo, Norway, and I'm a consultant gastroenterologist and a PhD student. And I'm working with T1 cancer, so this is perfect. I just stepped in from Ethiopia. Thanks.
Okay, as a colorectal surgeon, I'm very pleased to see the program today, working with treatment of all the largest cancers we find, or all the small cancers we find in the screening program. And I'm happy to invite the first speakers, Leon Moons from the Netherlands, who has an excellent randomized controlled trial against EMR and EST. Thank you.
Well, thank you so much. This is for us also a very happy moment after 5 years of hard struggle. But I want to present you the results of the Matilda study, which was EMR versus ESD. Well, you all know the discussion, I think, that EMR is what we have been doing now for the last 20 years. It is widely available, it costs not much time, it's easy, and it's low cost. ESD, however, is more time consuming, more difficult to do, a longer learning curve. However, the negative side of EMR is that it is associated with a higher recurrence rate and less optimal histological assessment, and that's the reason why perhaps ESD might be better, because you have a lower recurrence rate, and perhaps the in-stake would be that if you have an ESD, you would invest more in the beginning, but you have a lower recurrence rate, and at the end it might be more effective than EMR, which needs repetitive treatments. But ESD in the Netherlands we do for two things. One of them is, of course, if we think it is cancer. And the other discussion that's worldwide going on, should you do it in all large lesions? And I think this topic mainly focuses on the second question: do we do it on all large lesions without signs of invasive cancer? So the endpoint of the study was that there is a superiority of ESD on the recurrence rate at 6 months as compared to EMR. We included consecutive cases of referrals to 17 Dutch hospitals with a polyp non-pedunculated larger than 2 centimeters. And there was an indication, of course, for endoscopic treatment, and patients had to give informed consent. The exclusion criteria where there was a suspicion of a malignancy, so these were excluded. And it should not be a recurrence. And there was also no synchronous distal advanced carcinoma, which already required surgery, should not be present. And we also put in that extreme poor general condition, which would not say that the patient would survive 3 years of follow-up, which was the follow-up, should not be included. So we also did some quality control. Only a few centers were allowed to do ESD, and they had to fulfill some criteria. At least they have to do 25 classical ESD with an R0 rate of higher than 70%. The EMRs should be more than 500 EMRs per endoscopist. We had a discussion about how the EMR should be performed, and we included already the margin ablation at the beginning of the study in 2015 because of the expected efficacy by Michael Burke. And we trained the participants. So these are the results. Eventually 54 patients were allocated to either EMR or ESD, but there was some inclusion failures. So they were just to be benign. However, just prior to the local excision, a more experienced endoscopist looked at the polyp, and as you can see, 9 patients did show cancer at the beginning, so they were excluded. The second one is that because we were more involved in the recurrence rate than in the carcinomas, we also excluded the cancers which were detected after the local excision. And as you can see, there were both 11 in the EMR group and 10 in the ESD group. And also there were some patients who rather died before the first follow-up at 6 months, and these were also excluded. So that kept us out with 106 EMRs, 109 ESDs. There were 3 crossovers. The patients were allocated to ESD, however, decided not to be, wanted to be referred and decided to go for EMR in their own center. And eventually 10 ESD were tried to do ESD, but ended up in a piecemeal EMR. So we're going to present you the intention to treat, and that is by the arm which they were allocated to. And the as treated is how they were really treated. So if it was ESD or EMR. The 11 in the EMR, we found 11 recurrences at 6 months, and there was 1 recurrence in the ESD group. That was the primary endpoint. If you go to the second endpoint was the 5 recurrences in the EMR arm versus 1 in the ESD. And now we're going into depth on how it went on into the EMR group. Sorry, I have to show you this. We've got the baseline. We randomized, so it would not be very essential, but the age is the same, male is the same. We see the same locations in the rectum, which is the majority of cases. We see, of course, that there's also a large group of patients with polyps larger than 4 centimeters, and some were even 15 or 20 millimeters. We didn't have an upper limit, and that gives us a little bit of a disadvantage, as you can see later on. And the majority of them, of course, were high-grade dysplasia or low-grade dysplasia. These are the outcomes of the interventions. In the EMR group, the technical success was almost 99%. And the technical success was defined as the event that you, as an endoscopist, said that all the polyp has to be removed. So it's not that we did a classical ESD, it was we had to remove all the residual tissue, all remaining tissue. The unblock rate, of course, in the EMR group is only 11% versus 91% in the ESD group. The horizontal or zero resection margin is 2.8% in the EMR group, as to be expected, and 76% in the ESD group. The duration, of course, is much longer, 94% in the ESD group. But we also had some perforations, and these are perforations after the intervention, so they needed surgical therapy. And the one thing was that 3 were perforations, 2 had segmental resections, and 1 had a rectal perforation, which caused the surgical on-call to place diverting ileostoma to support the healing, and that was restored. And there was 1 stenosis after a large, completely circumferential ESD in the sigmoid, which caused stenosis, which was also solved by colostoma. We had post-coagulation syndrome, and as you can see, the emergency surgery was 4 cases in the ESD arm. These are the recurrences in the EMR group. There, of course, were no recurrence in 95, but and they went straight on to the next follow-up, which was 36 months. And in these cases, 2 additional recurrences were detected. In the 11 recurrences detected at 6 months, they were treated, and by the next stop, which was 6 months later, 8 had non-recurrent. But eventually 3 of them developed a recurrence after 3 years, of 1 of them being malignant. And these patients had to be treated with short radiotherapy and APR. 1 of the 11 recurrences was a malignancy, diagnosed at 6 months. And there was 1 recurrence which had been treated again and again and again, but eventually ended up with no recurrence. So if you look at the primary endpoint, we can say that in the EMR arm, there is a 10% risk of recurrence at 6 months and 0.9% for the ESD, which makes a risk difference of 9.5%, is making proving superiority of ESD. And in the S-treated analysis, you can see the same, that it is even a little bit higher, but still the same. So ESD would be superior. However, and I must say that this is a secondary endpoint. We've lost a lot of patients, more than we expected, 15%, due to all-cause mortality, dying of another cause, other cause of cancers. And I know this from T1 cancers, that we lose a lot of them to another cause in the first 3 years. So we have to keep in mind that not all patients will survive the follow-up period. And then you can see that with all the additional treatments, the recurrence rate at 5 years, of the 3 years, is 5% in the EMR arm and 1% in the ESD arm. And that's not different anymore. So we are very close. Yeah, I'm going to speed up. So this is essential because people really want to know how is it with the covert. Well, one of the thing is that not all coverts are T1s. We recognize that there are T2, T3s. And that's the same as with Michael Burke saw in his cohort. So you only solve, in our cohort, but it's very too small, only 3 cases with low risk. So this comes up to the surgery, that the difference in surgery is not so big in our cohort. So at the end, I think our superiority is proven for ESD at 6 months, but you might argue whether it is really effective at a longer time point at 3 years. We did see a low risk of recurrences we didn't find a difference at 3 years. The cost effectiveness is now currently being worked out, but it's quite likely, and we assume that it will be that ESD is not cost effective as compared to EMR. EMR is cheaper than ESD. So for the endpoint recurrence, ESD for non-invasive polyps might not be the first route to take. Thank you.
So, okay, thank you for a great presentation, Leo. We're moving on to Maria Police. She's going to talk about the staging of rectal polyps. Is there room for improvement? So take it away.
So hello. I think that this talk goes very well after the one from Leon. So I will start by showing some pictures of lesions in the rectum, and I would like to ask the audience to raise their hand on in which ones they would do a pre-staging staging before taking any treatment decision. For example, this lesion from the rectum, who would do a staging modality before deciding on the treatment, like who would do an MRI, IUS, or would directly do a treatment. You would do something, no one else. And in those lesions, who would go directly for treatment or who would do a few more, but not a lot. And in this lesion, for example, in the rectum, 10 millimeters polyp, 12 millimeters polyp. This one, the surgeons, for this one, okay. So, and for this one, so there is no many clinicians in the room, I understand, if you don't raise your hand. So probably there are very few clinicians in the room. Okay, so this was because I would like to talk about the T1 cancers in the rectum, but we know that T1 cancers now account for around the 40% of the cancers that were diagnosed, and that most of these T1 cancers will raise into a polyp. And also, as Leon was saying, sometimes in this polyp there can be also more than a T1 cancer. So the fact is that rectal cancer sometimes is around 50% of the cancer, so that means that in the rectum this is a big debate, and we need to do that staging to decide the treatment modality. No? As it was already stated, we have different options in the rectum. We have a lot of options. One options are local resections with ESD, EMR, TAMIS, EFTR. And on the other hand, we have the oncological options that will go through oncological surgery and neoadjuvant therapy or other therapies. So each of them has pros and cons. Of course, the local resection techniques are organ preserving, are cheaper, less complications, and better quality of life, and the other ones are more secure in terms of oncological outcomes for the ones that have a risk. So what we do with a rectal cancer to decide how to manage them usually is to do a general staging, a CT, but we also do a local staging that is the one that will help us to take these decisions. For many times there were two options: endoscopic ultrasound that could be done with a rigid endoscope or with a flexible one, and MRI, and there has been some discussion on which one is better for T1s without a clear consensus. And here is some of the guidelines that shows that for T, it looks like a US could be better from MRI, and some guidelines suggest to do US for these early cancers. And for end stage, it looks like MRI could be better, and most of the guidelines recommend to do MRI. But the truth is that when we are thinking of a T1 cancer, there is not a lot of closed questions, and on the other side there are plenty of open questions, like should we do a staging in all the lesions in case they have a T1 before any decision? Should we only do it in some specific ones that we think that could be a more deep cancer and more advanced cancer? Should we do it before or after the local treatment? All those questions are not very clear, and there is great heterogeneity in clinical practice. So this is why we decided to run this analysis, which is based in this PT1 consortium, which is a multi-center retrospective cohort study with 33 health centers in Spain from 12 different states in Spain, and which we have put all this data in a REDCap base with a lot of variables, and the point of departure was to include only those patients that were already known as a T1 cancer by histology. So I will show in this analysis we just took all those patients from the large database, all those ones that had a T1 rectal cancer, and in which we had a complete information on the staging that was done prior to treatment. So at the end, we have from the 3,600 patients, we have 600 patients that were included in this analysis. Here you can see what happened with those patients, and you can see that most of them underwent a local treatment as an initial therapy. A quarter of them went to oncological surgery directly because they were thought to be a cancer from the beginning, probably. But many of the ones that had local treatment underwent afterwards a secondary surgery. So at the end, we have have more or less half and half of the patients that went only with local treatment and the other half that had finally an oncological surgery. Here are the general outcomes of the cohort. You can see that from the ones that had a local treatment, 14 presented a recurrence. That means that with the follow-up, we have at a minimum of 3 years of follow-up, there were 14 that had that recurrence. That means that in these 14 there was an under treatment, probably with this local treatment. And when we look at the ones that had surgery, we can see that most of them didn't have anything on the specimen. So the 38.6 were overtreated. And if we specifically look to the ones that had surgery, we can see that at the end, 88% of the surgeries were probably unnecessary. You can also see that from this cohort, the rate of adverse oncological outcomes that includes to have residual tumor or lymph nodes positive in the surgical specimen or to have extraluminal recurrence during follow-up was only 7%. So this is the characteristics of our population. Most of them were male. The age is around 60%. Half of them were diagnosed in a screening program and the other ones by symptoms or CT finding, and only a few by surveillance. Let me see. The lesion size was around 25 millimeters, but it's interesting to see that some lesions were really small, and half of the lesions were smaller than 20 millimeters. Also, when we look at the morphology, it's interesting to see that many of them were sessile or flat, but 20% were pedunculated. And when we look at the location, they were distributed all along the colon. And what is interesting to see and has been previously described by the people in Netherlands is that only half of them were suspected initially by the endoscopist. The other one were findings. So it's also interesting to see that when we looked who was handling those patients, this was different, but mostly it was gastroenterologists, surgeons, or in an MDT. Very few were handled by an oncologist. So now there's where we go. We looked how many of those patients had a staging modality around the treatment period. And as you can see here, there were most of them had it, but a few didn't have it. And when we look which one was the staging modality, the preferred staging was MRI, then both MRI and US, and a few had only US. We looked at the factors independently associated of having a staging, and it is interesting to see that apart from some factors that will be very logical, like having a high-risk feature or being located in the low and middle rectum, there were other variables that were more depending on physicians or on politics, like being a reference center or not, or being held by a gastroenterologist and a gastroenterologist, and also the fact of having a suspicion on the lesion. Here is the accuracy for the T, and it's quite striking to see that the accuracy for the T was really low. Of course, our cohort is only constituted by T1s, so we don't know what happened with the ones that were not T1s, and we only can know about overstaging. And as you can see, with US, 40% were overstaged, and with MRI, 71 were overstaged. Generally, more than half were overstaged. We did a multivariate analysis, and what we saw was that this was especially bad for MRI in non-referral centers, where the fact of being a referral centers or not changed it a lot, whereas for US it didn't change so much. For the end stage, things were better, so the accuracy was better for both techniques and quite similar. And here you can have the sensitivity and the specificity and negative predictive value of each of them. And as you can see, the specificity was quite good, but sensitivity and positive predictive value was quite bad, especially for US, but also for MRI. We had a few patients, 73, that had both techniques, so we could look in those patients what happened. And again, you can see that for the T, MRI was worse than US. And for the few that had these two tests together, we can see that for the N positives, there was only one patient that was N positive, and that was not catch up by MRI nor by US. And when we look at the other ones, the ones that were finally N0, so that they had a surgery, it was quite similar, the mistakes and the correct in both groups. So in summary, the staging was done in around 60% of the patients. There were some factors associated with the fact of having a staging that were depending on physician, like the management in a reference center, and the fact of being a specialist or a gastroenterologist or not, and the fact of having a diagnostic suspicion on endoscopy. The diagnostic accuracy of US and MRI was lower than expected from literature. T1 rectal cancers were overstaged. For the T, in 2/3 of the cases. For the T staging, US had a better diagnostic accuracy than MRI, and for the N, US and MRI were quite similar with high specificity but very low sensitivity and positive predictive value. Of course, this study has important limitations. It's a retrospective study, and there will be a lot of heterogeneity among the health centers. We only included T1 from histology, so we don't have the information on all the other ones. And in order to have a follow-up, we choose this period, which is now quite an old period because there have been new guidelines, for example, from the ESGAR in the way of doing MRI, and probably this is not reflecting what is happening right now. But on the other side, we have these oncological outcomes, which are very important. We have real-life practice, and we are very focused on T1, which is not so common. So our conclusions is that the management of T1 rectal cancers is challenging and needs a multidisciplinary approach. We need more to work together. That the correct diagnosis and staging is warranted to provide the best treatment approach, but right now we have a lot of limitations. So I think that there is a need for innovation. In one hand, we need better techniques or improve the techniques we have to have a better way of diagnosing first and then of staging. And we probably need large multidisciplinary and prospective study with standardization of the protocols and with oncological outcomes to provide us with some answers. We need this multidisciplinary consensus and guidelines, and maybe we need to enhance the standardization and quality control and what we are doing in our clinical practice in the general community. So thank you very much.
Thank you very much. And now I'm pleased Maria has just very nicely showed us how difficult it is to correct stage. And now we're going to Natasha Pilonis, who's going to show us how to actually to handle the early cancers. Thank you.
Thank you for the introduction. Welcome, everyone. I feel like this Maria's excellent talk just started. This topic is a very broad one. But let me give you just a bit of background why this is very important that we here today, that we are discussing this together. So PT1 colorectal cancers are becoming the most frequent ones that are diagnosed within a cancer. And this is good because a higher proportion of early cancer stage, this is better for our patients because their prognosis is better. However, our present standard treatment for the PT1 early cancers originates for the time when there were small numbers of those detected, and namely this is a surgery. So as Maria would have in the background of overdiagnosis and unnecessary surgeries, we do need more evidence-based, less invasive, less burdensome, cost-effective, and environmentally friendly approach for management of PT1 colorectal cancers. So looking at available evidence and looking at our clinical practice, I think there are five key questions that has to be answered in order to optimize our management of PT1 colorectal cancer. So we should we should determine what is the optimal primary treatment for PT1 colorectal cancer and what is the optimal primary treatment for PT1 rectal cancer, because as we heard from Maria's talk, this is a bit different from colonic one. we have to determine how to manage incompletely resected PT1 colorectal cancer, how to identify high-risk PT1 colorectal cancer before we will handle the treatment, and what is the optimal management for high-risk PT1 colorectal cancers. So let's start with the first question. How to choose the optimal strategy for primary colonic cancer. So we have the data to support non-invasive endoscopic local approach, and this recent meta-analysis of almost 20,000 patients showed us that within the first 3 years after the treatment, there is no difference in terms of overall survivor recurrence or disease-specific survival when we compare patients that were treated locally with endoscopy and those with surgery. However, we can see that this surgical treatment was associated with a higher rate of procedure-related adverse events. This is a good argument for local treatment. However, when we see at this meta-analysis, with a higher follow-up period up to 20 years, we see that with a longer follow-up, those differences start to be more prominent and maybe not as favorable for endoscopy as in the previous one. So this gives a case for those who support surgery, and this is a valid case. But unfortunately, this is data, of course, retrospective data and anti-rec data cannot lead us to the optimal evidence-based decision. So this gets even more tricky in terms of rectal cancer because of the anatomy of rectum. We have more ways to approach the cancer locally. So we can do this endoscopically, and we can do this with minimally invasive surgical approaches. So we know that standard TME, total mesorectal excision, is associated with a very high morbidity and relatively high mortality. And when we will confront this with early cancer, this is basically unacceptable. So the most common technique for ESD seems to be not optimal for those cancers because R0 resection margin can be achieved only in around 60% of patients. However, those surgical minimally invasive approaches, they are characterized by the high risk of recurrence up to 30% and non-negligible long-term negative functional impact, which is of course lower anterior resection syndrome, which can be even 20% throughout the 5 years after the treatment. So what's there new and what our hopes in? So there is something in between ESD and those local surgical treatment, which is called endoscopic intramuscular dissection. So this method was introduced by the Dutch group and Leo, who is sitting here today. This is basically resection of the lesion in between two muscle layers. And a very promising case series study showed us that the very high technical success, excellent R0 resection rate for deeply invasive mucosal cancer, which is 90%, and only minor adverse events. And this group just recently in Dublin, they showed the data on a larger cohort when they were with a longer follow-up, when they were able to assess the functional impact of this procedure, and it looks like the LARS was noted, major LARS was noted in 6%. So we see that it happens, but definitely less common than in our surgical alternatives. So another big question is how to manage the cancer that was already resected, and in the histopathology assessment, it appeared to be incompletely removed. And it happens very frequently. Maria just told us in Spanish data, we see this from the Dutch data. Basically, the majority of cancers that are seen by the endoscopists are not recognized as cancers. So they take a snare, they choose not optimal technique to ensure R0 resection, and then we have this situation that we have to deal with. We could say that, okay, there is a scar, maybe we should do just optical surveillance and surveil those people, not to send them for surgery, but we have some data that only this approach has sensitivity less than 30%, which is not acceptable for patients, of course. So there is a new emerging technique that can be a valid alternative for the surgery, which is an endoscopic full thickness resection of the scar. And we have some data, indirect prospective data from the Dutch group that showed that a large cohort, more than 400 patients, in direct comparison of the EFTR and surgery for this indication. So in terms of oncological outcomes like metastasis-free survival or overall survival, there was no difference. So this is quite promising. And another case of this procedure for colorectal cancer shows that this is relatively safe technique, but we have to account for around 10-15% of patients who will need surgery anyway, for either for oncological safety, for adverse events, or for other causes. Then another important question is how to identify high-risk PT1 colorectal cancer. And I think we have to acknowledge this important meta-analysis from Dr. Zwager just last year, who showed that what we thought, which is deep submucosal invasion as a high-risk factor, is not a case anymore, and as a single risk factor is not associated with the lymph node metastasis, contrary to the poor differentiation, lymphovascular invasion, and high-grade tumor budding. However, they have different significance, and still we treat them as the same. So this is also a very general approach that we take to identify high-risk patients. How we can do this better before the treatment, and whether we can identify the high-risk patients before the treatment. So new emerging translational research showed us that this is potentially feasible. This recent study of 200 patients, when the cohort of mixed lymph nodes, positive and negative patients, were compared with their microRNA and mRNA panels. So this showed that quite promising ability to differentiate between those two groups, and the authors showed that this approach could reduce overtreatment from 90% to only 80%. So this looks promising. And just at the end, I don't want to talk about this very long, but of course, this is a very broad and important aspect, how to manage in an optimal way high-risk colorectal cancers. And this is the field when oncology surgery, endoscopy, and gastroenterology meet. And we really need some multimodal approaches. And teaser trial results are on the horizon, and we will see in a rectal cancer in a randomized fashion how this chemotherapy for those patients after treatment or completion surgery or just watchful waiting would be the most optimal approach for those patients. So in a summary, emerging evidence suggests that endoscopy should be a primary treatment for PT1 colorectal cancer. There are new emerging treatment modalities for PT1 rectal cancer. Endoscopic full-thickness resection is a good alternative to surgery for incompletely removed colon cancer, and there are some emerging non-invasive molecular predictors for lymph node metastasis in PT1 patients. And it appears that multimodal approach is a way to go for high-risk PT1 colorectal cancer. However, we need some direct comparison, and we really need the evidence to make our decisions based on the evidence, not from the indirect data. Thank you.
Thank you, Anastasia, for yet another great talk. Thank you. Are there any questions from the audience? Yes, please.
So this question is to Leon Moon. So as far as I could understand, your study kind of showed that you had a lower rate of recurrence, but a higher rate of complications for the ESDs, right? But they also had much less experience. Isn't that correct? So my question is actually like, do you think that there is some kind of learning curve affecting your study?
I totally agree that the 3% perforation rate and the 4 cases of surgery is, to my opinion, quite uncommon now. So we started in 2015, so it might be indeed a little bit of a learning curve in the beginning. However, it didn't affect the cost effectiveness itself, strangely. So I think that we should try to lower the risk of complications. But the main point is that I think that the EMR can be quite effective in most cases. And the malignant recurrences were 2. And the fact is, do you want to treat all these large lesions to prevent these 2 or not?
Thank you very much.
Thank you. First of all, to congratulate both Maria and Leon Mons, both of you, on some really fantastic studies that you've presented, because it's real-world data. I suppose the question is common to both in terms of the themes, one of being the case selection. Do you think it's really interesting that 15% died of other causes that you showed in your study? Do you think there is a case there in how we select our cases for these procedures for the maximum benefit and again the cost benefit to be realized? And similarly, from a case selection perspective, do you have data on what was the total number of polyps by some predefined criteria from which those T1 cancers were retrospectively derived, really, in your study?
Totally. I think, well, Leon has more experience, but when you work with T1s, one of the conclusions that you arrive is that the weight that will have this colorectal cancer on the life of that person is very, very minimal in comparison of all the rest. So we are working a lot and trying to very much understand what is the best way to go, but at the end, on the effects of the patient, fortunately, T1 cancers have very little recurrences, and the mortality of these recurrences is not 100% either. Whereas we are talking about a population that is usually elderly. So this is something that needs to be taken into account. But at least for the EPT1 consortium, this was not a variable that we could have with good quality, because it's just retrospective, and you know that many of the things were not recorded in the past. So we have it from undirected things, like if they were smokers or not, and the ACA for anesthesia, but this is probably not showing what really is happening. So I think that we should have a Charleston score before any of these procedures always, and we should include that in any decision tree. Because as you say, I think that this has much more weight than we as endoscopists we want to admit. I agree.
Thank you. Leon, did you want to add anything?
We did a study. We looked in our T1 colorectal cancer database, and about 700 people died within the time period of 5 years. And that's quite normal as compared to the normal population. So I think we overestimate the survival chances of our patients. And what we clearly saw, that as the Charleston comorbidity index, which could be determined in our case, was predictive. So we advised them to not for doing the local excision, but whether to go for completion surgery, we take that into account.
Which really emphasizes the point, so thank you. That's really helpful.
So I also have a question to Leon. So do you think that we should have a different approach to rectal and colonic lesions with EMR and ESD? I mean, there is an ongoing debate between different people around the world. So what is your take about it?
Our study looked at the recurrence rate in the rectum. So the main reason why I would advocate doing ESD in the rectum is for another endpoint, and that's the prevention of cancer and the impact of surgery has on the rectum. But we're not allowed to say something about that with our study because we only have 21 non-recognized cancers. So that's too low to say something about how many of them we can have cured or not. But I think that going up into the sigmoid and especially going up to the ascending colon or transverse colon, I believe that doing ESD for all large lesions is not the way to go. But that's yeah.
Why?
But why?
Why do you think so?
Why? Because I think that the problem of covert SMIC, what's it called, is a problem of the rectum and the sigmoid, and not from above. So the majority of the lesions, the large lesions in the proximal part of the colon, do not have this same risk of submucosal invasive cancer. It's about 5 to 6%, and that's even lower than what we have now encountered in our cases.
Matt Rutter from the UK. So just building on that point, so if ESD isn't appropriate for all, did your study identify any factors, any features that can help predict who does need ESD as opposed to who can have piecemeal endoscopic mucosal resection?
We're looking into that because we have now real-life data about the costs which were made, and now we really want to see at which thresholds ESD is more effective than EMR. But that's coming, so I can't say anything about it. It's very too premature.
I'm glad you're working on it. And I guess just to advocate for complex polyps, MDT, multidisciplinary team meetings. So we've introduced those in some, not all centres in the United Kingdom, and they're very effective. It's a bit different from having a cancer MDT. You need to have the expert endoscopists in the room. But I think the decision making, as we've all alluded to, is really key. And getting it right first time is an important message. So I would strongly push for those meetings to be set up.
Maybe it's not my position, but I want to ask you a question then. Because do you introduce an MRI? Because what I spoken to doctors from the UK, they oftenly perform MRI, even for non-invasive large lesions in the rectum. And seeing the data from Maria, how do you think about that?
So we don't use it universally, no. I think there is a risk of overstaging, which can drive you down the wrong management pathway. So I think if for carefully selected cases, it can be helpful, but I don't advocate it for every rectal lesion, no.
So then I have a question to Nastasia. I mean, you've opened 5 big questions for 5 important topics. So do you think that we need some kind of a, let's say, pan-European collaboration around this topic? Because this is not going to be answered by a small center or even large center. I mean, we need numbers to inform ourselves on what is the best approach.
Yeah, Michael, I think you got the message of this presentation really well. That's the point. And of course, those trials, we think they need to be done, and they will be very, very difficult because to randomize patients in between something which is more invasive like surgery and then less invasive than endoscopy on the basis of the data that we already have will be very difficult. So I think the number of institutions, the number of countries that need to be involved to make those trials successful will be very, very high. So I think that's why I'm very happy that we have this meeting every 6 months, so we can remind ourselves that we really need this cooperation to make it happen.
Okay, thank you. And in time, this has really have been inspiring, opening a lot of new questions we have to solve in community. So thank you for keeping the time, even though it has been very difficult with such extended themes. So, and thank you for your very lively involvement for the audience. And sorry, now I want to we want to go on to the next theme and ask for the next chairs to come up here.
Great. Absolutely, that's great. Perfect.
Yeah. Good afternoon, everyone. Let me just first briefly introduce myself because I'm new to the schedule. I'm Willemijn Klaver, a researcher from Amsterdam, and I'm very happy to introduce the next session. Please stay engaged before the coffee break. I think it's a very important topic because it's about keep improving colorectal cancer screening, namely with introducing novel screening tests. So that's where the next session is about. And this is my co-chair.
Hi, my name is Doug Corley. I'm from Kaiser Permanente in San Francisco, and really looking forward to this session. Again, this is kind of some of the future of where we're going to be going, and look forward to hearing what people have to say. Welcome, David Weinberg. David is the Chief of Medicine at the Fox Chase Medical Cancer Center in Pennsylvania. He's also the co-editor-in-chief of Gastroenterology, and he's going to be talking about a very interesting and potentially controversial topic, which is multi-target testing.
Thank you. I think I speak for everyone in saying that this session, either at UEGW or DDW, is always an extraordinarily well done process. And once again, thank you to the organizers, and certainly thank you for the invitation to me. As Doug suggested, I get to talk about sort of colorectal cancer screening, but probably some would argue what will replace everything that we're talking about now. Which means it's probably time to go to the bar. So I have no relevant conflicts of interest to declare. This is the last group that needs to understand what a standard cancer screening paradigm looks like, with the idea being that you detect people optimally before they become symptomatic. And there are obviously a variety of different techniques that have already been described today. The ideal screening test would be sensitive and specific, inexpensive, easy to administer, able to detect disease at a point that's early enough to meaningfully intervene, and it has few false positives. I think one might reasonably argue that of the variety of colorectal cancer screening tests that we talk about, none actually fits all of these criteria. Nonetheless, in the United States, which I'm asked to present, but I'll ask you to extrapolate to your own countries, the current recommendations for cancer screening in the United States focus on 4 cancers. The United States Preventative Services Task Force, the governing body that makes recommendations about what cancer screening tests will be paid for, recommends screening for only 4 average risk cancers: colorectal cancer, cervix, breast, and for smokers of an adequate degree, at least, lung. And the idea basically is that a positive screening test leads to an organ-specific workup. It's one disease, one organ, one kind of evaluation. The test characteristics, sensitivity and specificity, for the 4 cancers that screening is recommended for are highly variable. Again, speaking for the US, the uptake by users, patients that is certainly suboptimal. And a concern in the United States, given our size and the relative diversity of our population, is that there are huge disparities in utilization. So what's the problem with the one test, one cancer idea? Well, unscreened cancers make up 60% of all cancer diagnoses in the United States and 70% of cancer deaths. So we just don't have screening tests for 70% of cancer deaths. The aggregate false positive rate, if you add together all of the single organ screening tests, is 31% for men and 43% for women, representing, of course, the extraordinarily high false positive rate from mammography. The annual incidence of other cancers, that is non-screen cancers in the United States, is 2 to 24 times higher than single target sites. So arguably there is a role for a new paradigm instead of the one organ at a time approach in the left panel of this. What about a universal, or in this case, probably a blood-based screening test, which will be the focus of the rest of this talk? In theory, it would allow for a simultaneous multi-organ detection program. It could potentially include all cancers. It's a single medium, easy for patients to do. It would be efficient and highly integrated, and there have been fascinating discussions of the challenges in Latvia and Romania about how to get people to do things. Well, getting your blood drawn is a lot easier than most of the things that we ask patients to do. And potentially it's cost saving if the test itself can be offered at a reasonable cost, and as we'll talk about, the evaluation could be done in a cost-effective way. Today we'll focus on liquid biopsies. Obviously there are many compartments that you could get patient samples from. Blood is the easiest. Urine might be even easier than that. But most tests focus certainly on blood-based testing. So this is in contrast to the slide I showed you a moment ago, where this would be a one test, many cancers approach. Now, this slide, which I put together a while ago, is undoubtedly out of date. SCED to your left means single cancer, and MCED to your right is multiple cancers. There are any number of companies in either the single cancer or the multi-cancer space, and those in the middle of the Venn diagram, at least when I made this slide, have offerings probably that fit into both. Why the focus? Well, it is the United States, and we always worry about money, and this is where the money is. So the estimate in the US alone for multi-cancer detection tests by 2030 is this is a market of nearly $3 billion, which gets nearly every company's attention, of course. So why? Well, this is a slide that I proudly borrowed from Dave Alquist, who some of you fondly remember. And he makes several assumptions in putting this slide together. So if you look at the left panel, number needed to screen is on the y-axis, prevalence is on the x-axis, and as prevalence increases, the number needed to screen, of course, goes down to find any single test, and you can follow, obviously, this is limited just to the GI tract, esophagus, stomach, liver, pancreas, colorectal, I circled just because it's what we're talking about. And if I can see it, looks like, at least on my own slide, the answer is 167 people would need to be screened to find a single cancer representing the point prevalence in the United States of colorectal cancer. If you follow that same curve all the way to the bottom right, you'll see universal, which is you would need to screen with a perfect test 33 people to, with 33 people to identify one cancer. And I believe universal in Dave's slide is any cancer, not just GI tracts. However, if you move to the right side, you see the problem with this strategy. Even as the prevalence of disease goes up, and even with a test with nearly perfect sensitivity, even at a specificity of, say, 97%, the middle curve, and by the way, we don't have any test that is 97% specific in this setting, the positive predictive value for all cancers would be 40%. In other words, 6 out of 10 patients would have a false positive test. So what are the arguments, and where am I going with this talk? This talk ultimately gets to, in my 12 minutes, a United States NIH-based initiative to study how you would use these tests. Not how well they work, but how you would use them. So the theoretical argument in favor of a blood-based test is there's roughly a 1.3% annual incidence of any cancer in the US. That's about 100.2 million cancers in the US a year. The cumulative detection rate these days, using the United States Preventive Services Task Force test for the 4 cancers I told you, is 16%. If you had a multi-cancer MCD, multi-cancer detection test that was 55% sensitive, and that number's not picked out of the air, that's what some of the early returns are, and even 99% specific, you would find 715 cancers in every 100,000 people, but you'd have a false positive rate of 691. And that's a cumulative positive predictive value of 51%. No one in the United States is currently recommending doing a blood-based test only. In fact, they're recommending combining standard of care screening for those 4 cancers plus an MCD test. And at least this analysis done in citation 2 suggests that this is at least modestly cost-effective, this combination approach. Well, what are the arguments against? Well, this is what we don't talk about so much. Cancer screening is built on the premise that early detection is always better than late. Well, that's just wrong. Many prostate cancers are detected early, and if they're treated, it's over-treatment. So there is an increasing awareness of overdiagnosis and over-treatment and the problems that it brings. Now, one could argue there are 3 kinds of cancers: slowly progressive, where early detection would help; rapidly progressive, where probably is no benefit to finding it early, it's still a very aggressive tumor; and then indolent. Prostate is a good example, where most men will die with prostate cancer, not of prostate cancer. At present, we have no way to tell which of the 3 kinds of cancers we're talking about. So this is just meant to visually describe what happens now. So in the upper left part of that curve, you see cervix, colon, and breast, and the benefit to harm ratio clearly falls on the side of benefits. However, as lesions become either, and now I'm moving to the right of the, x-axis, either rapidly progressive or the increasing number of indolent lesions, the benefit to harm ratio probably flips. And the concern is, where would a blood-based test that finds all of these cancers, fast, slow, indolent, etc., where would it fall? So no one knows. So anything I talk about from here on is purely speculation, not necessarily by me. I've given the citations for who's thought this up before me. But here's an interesting thought exercise. SEER data, which represents about 20% of the United States cancer burden, but is very representative of the whole country. If you use SEER data for the 40 to 79-year-old population, remember, the younger people get screened because it's not just colorectal cancer. If you downstage 1/3 of patients from stage 4 to stage 3, from stage 3 to stage 2, 2 to 1, etc., you'd end up reducing cancer death by about 15%, 1-5. So if you then apply that to the whole population, the observed number of cancer deaths after 5 years of follow-up would be 285 out of 100,000 people. And that 15% reduction, by the way, saves 71 lives. However, if you take a novel, doesn't exist yet, multi-cancer detection test with a false positive rate of only 0.5%, there would be 500 false positive cancer diagnoses for every 71 cancers prevented. Now, I would warrant that someone in this room has had a false positive cancer test, probably mammography. It's terrible. So think about what it means to tell a patient they might have cancer. Think about what it means to tell the patient they might have cancer we can't do anything about, but we found it. So there are many unknowns about multi-cancer detection tests. How do you work them up? How do you follow up positive tests where cancer isn't identified immediately? It's a lot of reassuring to be done for patients where you told them they have a test, they have cancer, but you can't find it. The potential harms of false positives, like overdiagnosis of indolent disease, we know that they exist theoretically, but we really don't understand the dimensions of them. How do you use this test? Do you do it once a year? Once every 5 years? Nobody knows. And then importantly, again, not just in the United States, but anywhere, how do you make sure that everyone gets to benefit from this test, not just people with easy access or the most money or the talk to their doctor the loudest to get the most attention? So, the National Cancer Institute, I'm about done. The National Cancer Institute has put together a trial. I'm embarrassed to say when my group applied, we didn't get to be in the trial, but Doug did. Not that I'm upset about that. The NCI trial is intended to assess willingness to be randomized, this patient's desire to be randomized to multi-cancer detection screening versus control, understand adherence, understand feasibility of workflows, determine the performance of various companies that want to use their test, because most of these are proprietary, and identify the facilitators and barriers to diverse enrollment in an RCT. This is the standard schema. It doesn't matter in our short time, but they want to enroll 24,000 people. Now, that won't tell you anything, let me underline, about how well the test works. This is entirely intended to see what patients think about this, broadly defined. So in summary, multi-cancer detection offers a brave new world. In the United States, many people will want this test. Demand by patients and industry to move faster than the science is always present in the US. It certainly will be present now. And the Vanguard study will provide some key preliminary information. And I know I'm running out of time, but this is Pandora's box. Those of you who know anything about Greek mythology have heard of Pandora's box. Does anyone know what was left in Pandora's box when she slammed it shut before all the horrible things came out? Hope, very good. Right, so hopefully, no pun intended, this will not be the case. We need to understand how to use this test, but to do it without thought, and for once, I congratulate the National Cancer Institute, they're doing this with thought, and hopefully we will get answers that we need. Thank you very much.
Thank you very much for the interesting presentation. A lot of food for thought, I think. The next presenter will be, let me check, Kevin Selby from Switzerland. He will tell something about the next generation Cologuard test, and hopefully he will be able to answer the question whether this new next generation Cologuard will actually enable the use of Cologuard more in Europe. The floor is yours.
I've been curious to see what this looks like after all the puzzled looks on people's faces, but it is a bit confusing. So I have no conflicts of interest related to this presentation. I did speak with representatives of Exact Science to know a bit more about this, but I have no stock or anything like that in this. So a bit about the original Cologuard. So the original Cologuard adds on to a fit molecular assays for aberrantly methylated BMP3 and NDRG4 promoter regions mutant KRAS and B actin. So, and what they do is that they look for these, and then there's a proprietary logistic regression algorithm that gives a positive or negative test. As you can see on here, it's not like a fit kit. It's like a bottle thing. So it's a collection of basically an entire bowel movement. And actually, all tests done in the world, because they're just approved in the United States, so all tests are processed actually centrally in Madison, Wisconsin. So it's actually not currently available or approved for use outside the USA. So that is the original Cologuard test. A little bit about the timeline. So it was developed by Exact Sciences. When you read back on it, it's quite interesting, actually, because they got FDA approval and Medicare reimbursement simultaneously in 2014. So they did a lot of pre-work to get this ready. And they got, because it was considered a new test, it wasn't actually lined up with any existing reimbursement. So they got a $512 a test reimbursement by Medicare. And then it got into the USPSTF recommendations in 2016 for a test to be done every 1 or 3 years. And they said that they should, clinicians should consider engaging patients in informed decision-making. It was integrated into the HEDIS quality targets. And actually, interestingly, there's a recent increase in use. From what I hear from friends who live in the United States, that now if you listen to NPR in the United States, you hear about Cologuard about every 5 minutes, from what I've heard. And a lot of this is based on actually very landmark work done by Tom Imperiali and a big team in 2014. So a really impressive prospective cohort of people who were getting screening colonoscopies received both a FIT and a multi-target DNA test, the Cologuard, before that. About 10,000 people. What you can see here is that there is an increase in sensitivity for cancers. There is an increase in sensitivity for advanced precancerous lesions. And then there's a fairly important decrease in specificity. So, and what is really interesting actually is it does seem like there was something novel with this test, that they were able to detect more sessile serrated polyps than FIT is able to. And it's always interesting to see this because I don't need to tell anybody in this room, but specificity has a big impact. So that drop in specificity, what's interesting is that if you imagine sort of a typical screening population, with that increase in cancer detection, you don't get much. You do get 7 more advanced adenomas, but what you can see is you have a very big increase in the number of positive tests. And then there was a very good cost-effective analysis study done on this that actually showed that if you did this test every 3 years, like it was being rolled out, unfortunately, not only did it cost more, but it was less effective, actually. If you assume that the 3 FIT that you're doing annually, as is recommended for the US, are independent from each other, and then you add up those 3 tests that you do with a 25% sensitivity for advanced adenomas, you would actually get more advanced adenomas from that than you would from the Cologuard. So now what are we talking about with the new Cologuard test? And so here I'm actually basing just on a press release. That is what is available right now, but there is apparently all the results will be at the American College of Gastroenterology presented there. So 23,000 participants, so an even larger study this time, with again a representative screening population in the United States. And this time they did the new next generation Cologuard test and a FIT, again led by Thomas Imperiali. So here are the high-level results that you can see that have been presented. So this was they specifically reworked their algorithm to try to improve specificity. That was the stated goal of this, which they did manage to do. So in the Deep Sea study is the New England Journal article that I showed you, and then the Blue Sea is the new study. And so the specificity went up from 87% to 91%. And as you can see, the cancer sensitivity, the high-grade dysplasia sensitivity, and advanced precancer is basically very, very similar. And so if we come back to our hypothetical population, so obviously with the same, you get the same number of cancers, the same number of advanced adenomas, and then you do come down a little bit in terms of the positive tests. But as you can see, even if the specificity at 91% looks better, we're still having quite a bit more positive tests than you get with a standard FIT. And then, so this got me thinking about the stool DNA tests. And I'm not sure, a lot of people in Switzerland have asked me about this test, Colo Alert. It's developed and distributed in Germany. It also samples stool samples for KRAS mutations, BRAF, and total amount of human DNA in occult blood. But they actually just have a single case control study, to my knowledge. People in the room might know otherwise. And actually the detection of adenomas is fairly poorly described in the publication. So it seems to have good cancer sensitivity and 92% specificity. But like I said, if people in the room know more about it, please let us know, because there's very little about the adenoma detection. So that's the article, if people are curious. Sorry. And then in terms of the other non-invasive tests, so I thought it was interesting to also follow up the Guardant DNA blood test. There's also a press release out about it, but it was interesting that actually the advanced adenoma detection by it was a bit disappointing, but they hit the 90% specificity target that they were hoping for. There is a large Freenome study, the Preempt CRC, that has completed enrollment, and there are publications out about the diversity of the population, but the results are not yet reported. Also, we just heard about the multi-cancer early detection. I went through some of what's published so far about the Guilleri blood test and the case control. 74% of colorectal cancers, supposedly, but there's really big error bars, so it's hard to know. And then actually the multi-target FIT, I don't need to talk about that because we have better results now for that. So in terms of based on press release information, the next generation Cologuard has similar sensitivity and improved specificity to the existing test. Specificity is obviously important, but the next generation Cologuard seems, if you look back on the cost-effective analysis that was done previously, it still seems unlikely to be more cost-effective, just because at the same sensitivity, if it's still more expensive, it's still probably going to be dominated in the cost-effectiveness analysis. And there are very important logistical hurdles. Talking to the Cologuard, it sounds like they were able to roll it out in Alaska, where they did pre-processing of stool samples and then had something that lasted longer that they could send to Madison, Wisconsin. But they haven't, but right now there are no plans to build these sort of very high-tech laboratory like they have in Madison, Wisconsin, anywhere else. So it's unlikely to change our approach to screening in Europe in the near future. Thank you very much.
Thank you very much for the nice presentation. Well, the floor is open for any questions, so please feel free.
Linda Rabenek, Toronto. Great session, and it's really great to hear about leading edge stuff. One thing, David Weinberg, I'm going to ask you about the MCD tests. You know, I guess the concern is while they're being evolved and they'll get better and so on, and we'll be in a better place a decade from now, I guess. But in the beginning, when you have a positive test, MCD test, it triggers a diagnostic cascade, doesn't it? And so endoscopy, CT scans, you name it, every time you get a positive test. And then in the case of a single payer system, the public system shoulders that. Even if the patient, you know, if it's not covered by the health insurance plan and someone pays out of pocket for it, the diagnostic cascade and that tab that's run up is placed on the publicly funded health system. And I guess it'd be interesting to hear your comments on with the Vanguard, and kudos to the NCI for funding this thing, whether the Vanguard is going to be able to assess that in a reasonable way.
Yes, all true. So as most of you know, there are currently two broad ways these tests work. One, the test spits out a organ of tissue of origin, sorry. So it's usually 3 cancers are named, and so the evaluation, although what's the evaluation is a good question. The evaluation is driven by the presumed tissue of origin. The other kind of test, which is the one that's best reported, this was the DETECT-A study done by Hopkins and Geisinger Health System 4 or 5 years ago. The test is simply positive or negative, and then patients get a PET CT, and that's supposed to localize the cancer. Now, think about, say, pancreatic cancer, not an easy diagnosis to make often. So you could imagine a diagnostic scenario paid for by someone where you get, pick your poison, CAT scan first, an MRI first, an endoscopic ultrasound of the pancreas first. But all of those costs will need to be factored in. And then, as I said, I don't know how to weight the costs of, and then the evaluation is negative, but you still have a positive test. What do you do then? So at this point, we can only, someone, not me, can model how cost-effective this is, but it requires, like any model, agreeing on, okay, the evaluation for potentially pancreatic cancer is this, the evaluation for colon cancer is this, the evaluation for ovarian cancer is this, and if those are the 3 tissue of origins, how often do you work your way down? I mean, there's so many unanswered questions that I think we can't even figure out how much this will cost. Plus, how much should the test itself cost? What's the willingness to pay?
Veerle Coupé from Amsterdam. Thank you very much for very nice presentations and raising interesting discussions. I would like to continue from your comment. You have already raised many concerns. It's obvious that you think this might be the box of Pandora. Just to add a little bit to that, you say that one of the possible applications, if we consider this, is to leave the current screening programs in place, but use this as an add-on. Are you not very much worried that simply the fact that we have the multi-cancer test will people not go to the other programs anymore? The participation will go down and maybe the consequences will be even.
No, I think that is a completely predictable, unintended consequence of trying to do the right thing. And the question then is, well, who's trying to do the right thing? I mean, presumably the healthcare system, maybe. Doctors, maybe. Certainly patients want to do the right thing. But you are absolutely correct. As was pointed out, just for colon cancer screening, they've now completed 2 trials, or almost have completed 2 trials in the UK, where they haven't said we're only going to enroll people with cancer. So it's not a screening study, but it's getting closer. And I think the sensitivity for colon cancer, as pointed out, was around 75%. Obviously, we have much better tests than that, at least hypothetically colonoscopy is. But if people stopped pursuing any form of colon cancer screening, thinking this test is going to work just fine, you're right. I think there will be many cancers that don't get picked up.
Yeah, I know we have prevention rather than only downstaging.
Wise choice of microphone. Why don't we switch over to here?
Sorry, can I just interrupt? We're actually measuring that in the UK. So we're actually measuring if we see a loss of take-up of screening as a consequence of patients being in the Gallieri trial.
Fantastic. And that's, again, it will be the efforts of many people, not just the NCI, to try to figure out if and how these tests should be rolled out.
Yeah, expectantly, I also have a question for Professor Weinberg. Recently, referring to the Simplify trial from our colleagues in the UK, where they showed that patients that were referred for unspecific symptoms as a kind of screening tool to determine how urgent the evaluation is, where an MSAT was performed, and what they really showed on unspecific symptoms for gynecological or GI tumors, what the distribution of cancers detected by stage was, which was roughly 20% for stage 1 and 90% for stage 4. So do we really need a screening test which shows the stage 4 cancers?
The unfortunate fact of life for all of us is that many cancers are only found by any screening test at a point where, at least at present, we don't have anything good to do about it. And again, I'm not wise enough to know whether we want a test that facilitates doing what we already do poorly, even more poorly. But that's me. I guarantee if we ask the people to raise their hand in this room, and I'm not, saying how many of you want this test, how many of you want the most information you can have about your health, I bet a lot of hands would go up in this room, acknowledging, just as you've suggested, Jasmine, all of the both the positive and negative aspects of this sort of testing, at least what we know about it now.
Yeah, so Dave, you probably really opened the Pandora box of, let's say, philosophical questions. And I mean, when we start considering having a multi-cancer detection test, should we, before moving into this field, try to have a closer look and redefine what do we think about a cancer? So to redefine the cancer, because it's a quite old-fashioned diagnosis, honestly speaking, and what we are really dealing with is that the cancer that we call cancer from histopathology is behaving differently as compared to what we thought when the diagnosis was coined. So, I mean, you and Doug, or maybe Doug, you has even more impact there in the US with the multi-cancer detection test. Maybe you should ask this question. Maybe we should all ask ourselves this question.
I mean, one of the other interesting twists, and first of all, incredible kudos to all of the people who developed all of the tests that we talked about today. I mean, advancing the science from the lab into clinical evaluations is incredibly difficult, and it's really one of the only ways that we advance. And it's one of the luxuries that we have of being able to now be like thinking about them in their clinical applications today. But I mean, I think the other part is just the question really of like whether the problem for most of these cancers is not having a screening test or not actually having effective treatments for early screen detected disease. This has been, ovarian cancer is probably the biggest example of this. You know, you can do an ultrasound every 6 months with huge trials, and you can detect a lot of early cancers, but the challenge is just that it doesn't actually improve mortality because there's not effective treatments for early screen detected disease. Same thing for CT scans. You could do a CT scan every 6 months and you would find probably the same cancers, but there's just not really effective treatments. So it is a very interesting kind of like conundrum, and hopefully we'll kind of continue to learn more as these progress.
Hi, just out of full disclosure, my name is Darren Lee. I'm actually from Mainz Biomed, and I just wanted to just add, I hate to be commercial, but if I can, we're actually just going to publish some data on Tuesday at the 4th International Gastroenterology meeting in Paris. Unfortunately, we couldn't make the UEG time for the breaking news here, but we are going to republish the data from 2018. It was a Dollinger study, and we've actually shown similar performance, 85% sensitivity, 92% specificity, and then 40% advanced adenoma. And we'll be publishing that and sharing that. It was part of a bigger study to look at mRNAs, and you'll see some press releases and things from the company and some more data coming up at the meetings. But I just wanted to give the update. Sorry to...
Oh, great, thanks very much, and great to have it in person and not just from the press release.
Hi, so your comment about health anxiety, which is what I think you were referring to in terms of what we all are, is clearly something that is driven by the media, everything that is going on with social media and X and whatever. And with, as you said, the commercial activity jumping ahead of the science. You know, one test every 3 years is not what it's going to be. It would be a test every year. So do we have any idea? You know, one of the criteria I think you maybe need to look at in the Mangas is what actually is the reproducibility of any of this testing? Because if you're getting a different signal every year, then the costs that Linda were referring to, again, go out of the ceiling. And I haven't seen anything on reproducibility in any of these studies so far.
We could undoubtedly go on for the rest of the afternoon talking about how this is an extraordinarily complex area. So we will undoubtedly have a chance to revisit many times.
Mohamed Yagoubi from MakeMaster. I just wanted to, again, add to that complexity that you mentioned. I personally think like having, and I think a lot of people are working on this as well, like adding a lot of other data to this would make the interpretation of these multi-organ tests probably easier in the future, including genetic, environmental risk factors, individualizing the screening method for a person that would have two potential outcomes. One, developing individual screening tests for an individual, and second, individual interpretation of a test in that context that would basically come up with a different pre-test and post-test probability for a person, indicating what to do with the results rather than treating everyone with the same. And I think eventually with the integration of AI in the next few years, we will have that. And I'm pretty sure a lot of people are already working on those. Just, again, an additional comment.
At the risk of sounding like I'm the ultimate nihilist, we could have said exactly what you just said about trying to personalize colon cancer screening through a variety of means. Exactly. And basically everybody gets colonoscopy. So an AI, maybe, but I think the science is way behind, as was just pointed out, what people want. And Pandora's box, at the risk of stretching my analogy, is already open. You can get these tests in the United States if you're willing to pay for them.
I have seen actually that in Canada, people coming from the States showing me this 23 pages of results, and they want me to interpret that.
Right.
I have no means of doing it.
Thank you very much, everyone, for the excellent presentations and for the great discussion. Don't want to hold you from coffee.
So welcome, everyone, to the final session of today, which addresses the very, very important topic of quality in colorectal cancer screening. We're going to have 4 fantastic speakers, which I'm really looking forward to their presentations. My name is Elisabeth Waldmann. I'm from the Medical University from Vienna, and together with Scandic Kodbyen, I would like to welcome our first speaker, Douglas Corley from the US. He will be talking about developing uniform global standards for colonoscopy quality, which defining threshold values and how to make practical. Please.
Thank you so much for the generous invitation to be able to talk today. I must say this is a challenging topic given all of the work that everyone in this room has been doing around this. And I think that the main question that really kind of comes up is exemplified by threading the needle between these 2 pictures, which is on the first slide. On the right-hand side is like all the stuff that we think about when we think about quality, and on the left-hand side is like the path of what we actually kind of want to be able to do, something that's clear, it's like measured, there's a nice light at the end, and not getting kind of tangled necessarily in all the complexities of being able to kind of like operationalize it. So conceptually, the Agency for Healthcare Research and Quality in the United States created what are called quality metric domains. I would proffer that these are, although it was an incredible task to do it, they're hard to define and measure. And these are around concepts of effectiveness, safety, patient-centered, efficient, equitable, and timely. And so in efforts to be able to look at this topic area in more depth, many people start here. And I think it's a great place to start, but then it gets to the question of like, all right, well, what do you do with it? In order to be able to kind of go a little bit deeper into that, and if we're talking about procedural type metrics, which is colonoscopy, the existing quality metrics really kind of struggle for evidence-based recommendations. So huge effort from the Quality Improvement Initiative, led by one of our esteemed leaders of this conference today, Dr. Kaminski, and in trying to be able to come up with what are some of the main things to recommend. And a very comprehensive document. This is just the top end summary of it, of things like, okay, these are things we should probably do. Rate of adequate bowel preparation, cecal intubation, adenoma detection, appropriate polypectomy technique, complication rate, patient experience, and appropriate post-polypectomy surveillance. You could probably see in yourselves, if I was going to ask you to define these things, even just like how would you define that? And that's one of the reasons why for some of them, it's like minimum not set, minimum not set, minimum not set. In some of those, I would even say like, how do you even kind of like define it to measure it? And for appropriate polypectomy technique, a minimum number was set. But it was interesting, the comment around it was that there are insufficient data to set the minimum and target standards reliably, but the proposed values seem relatively easy to achieve. And so sometimes it can be like, well, what is kind of like a consensus around what might make sense, or like what would you want if you were having to see a gastroenterologist or you weren't able to see someone? But then the question comes like, well, how is that actually really kind of like a quality standard, and what is it really measuring? So the plan for today is to really kind of talk potentially about which quality metrics, how to go about to defining the thresholds, and then the third charge was how to make it practical. So we approach this a little bit differently from a large consortium in the United States that I'm a part of, and really just talking on behalf of that group, of being able to define it a little bit different way for procedurally related metrics, at least. That it's measurable, that it's associated with an important outcome, and that it should be modifiable. Because if it's not something that you can change, then like, why are you going through all of the rest of the trouble? So the quality metrics for procedures kind of probably start on this pyramid base first of like, can you actually in some way, shape, or form measure it? So there are with this then the next step, of this group, and Kevin Selby was part of this. So you can from Switzerland, you can see at the bottom he published something just this year in JNCI. Was coming to be able to. There were 4 proposed domains. Like what are the things that people think are important, and then I'll give you an example kind of each of those. So like for one of them was that it's complete. Are you actually doing a complete exam? And an example for that, I'll actually, sorry, the way this will roll out, it will come back in a second. The second is it adequate? So for an example, for a complete exam, might be like something like complete to the cecum. You were able to visualize everything that you wanted. For a CT of the chest, it might be actually that all of the appropriate areas were actually like physically, the test was able to be completed. The second is adequate. You may have everything there, but it was, for example, wasn't an adequate bowel preparation. There may have been a blurriness or something on the CT scan. The next is safety. So this in some way, shape, or form might be complication rate, might be radiation exposure. And then the last is some concept around accuracy. And so this could include something like the adenoma detection rate. So for those, again, just for the examples for today, might be like 2 cecum, good prep or adequate polyp resection. Safety might be a complication rate. And then accuracy might be something, such as adenoma detection. So the next question is it modifiable? So a lot of people have done work around adenoma detection rate. So I'm just going to put that out there as something that I think is one of the stronger ones that we've been able to develop within gastroenterology in terms of some of the evidence. And in terms of modifiability, there have been a few different studies. I think there has not really been any extremely large multi-center randomized trials that's something that's kind of generalizable. This was just an example from Kaiser Permanente in Northern California that was published earlier this year. So for those folks who aren't familiar, Kaiser Permanente in Northern California, it's about 22 medical centers, about 5 million people. There's about 9,500 physicians, and it represents about half the people in Northern California. It insures about half the people in Northern California, and has a representation of being relatively census-based, similar to the underlying population. But this was just an example of feedback being given over time, and then a relatively simple online interactive that was designed kind of like from the ground up using a kind of like evidence-based techniques as opposed to kind of like a top-down measurement. Top-down estimates of kind of like what people should know. And what you'll see on the bottom is that the top people are the top half of adenoma detection. The intervention, takes 30 minutes. Everyone in the group had completed it. Didn't have that big of an effect on the high detectors, but interestingly on the low detectors, almost immediately there was a jump of about 5%. 5% doesn't seem like that much in absolute terms, but what does that translate into? That actually translates overall of this whole time period between these things, between giving feedback. There may have been other factors, better bowel preps, other things, but adenoma detection rate over this time was modifiable. It increased over this. You can see there's 12 quarters before and 12 quarters after the middle, from 25% to 40%. That's a pretty big increase overall. The intervention actually had a prompt 5% higher lower detectors. That translates into about a 25% reduction for their patients in their risk of post-colonoscopy cancer. That's actually a pretty big relative risk reduction for a 30-minute intervention. There was decreased variation, and overall, over this time period, there was approximately about 50% fewer post-colonoscopy colorectal cancers. That would suggest you can not only modify ADR, but there was this association between reductions in ADR and what you're interested in, which is cancers. So again, a pretty nice metric overall. It seems like to be measurable, seems to be modifiable. If people are interested, this is actually available online, and we use it also as for part of our quality initiatives if someone has a lower adenoma detection rate. So there are several steps, where detection can be improved. There's the pre-exam part. There is, in terms of the addition of a second dose, for example, the split prep. There's the technique, which is similar to what we were just describing for adenoma detection, and also other methods that might be used to improve physician technique. And then there's also tools. There are a number of different tools that have been discussed. AI is just kind of one of them, but all of these might improve something like adenoma detection. And Doug Rex did a really nice summary of these just this last year around colonoscopy quality, and it was in gastroenterology reports. So those are probably which quality metrics to choose. I'm not saying exactly which to choose. We'll touch base on those a little bit in the how to make it practical part, but at least conceptually, it's a place to be able to start if you're going into a process of, we are writing a set of quality metrics, or we are going to try to be able to implement something which is in our setting. The next is trying to be able to define the thresholds. The first thing I think is probably to decide, maybe up front, maybe after you have the data, are you looking for a floor? Are you looking for a target? Are you looking for something that everyone who's doing the procedure needs to be getting above? Or are you looking for something which is aspirational, that like this is something that we are trying to be able to achieve? You need to define the threshold and then understand and identify what the potential data sources are. Sometimes there's actually like almost no information at all. Other ones, it might be expert opinion, like, oh, well, someone should be completing a colonoscopy at least this percentage of the time. Other times it may be data-driven, and then there's also the highest level, which is trial-level data, which is pretty uncommon for quality metrics. You know, most of the stuff we have is kind of there in the middle. This is just an example. Again, a number of folks have looked at this. This was published from the Prosper Consortium I was alluding to earlier last year in JAMA. And each one of these lines is a different adenoma detection rate. The bottom is your time after colonoscopy. And then on the left-hand side, it's your cumulative incidence of post-colonoscopy colorectal cancers. So this is like when you're coming into it from the patient perspective and you're saying, who would I like to have as my gastroenterologist, and how does it matter that much? The top line, maybe not so much, less than 20%. The next line down, as you can see, it kind of continues to go down. But one of the things that we found, at least for screening colonoscopies, was that there was this relative convergence when you started getting above around 35%. Now, this is probably partially related to the time after colonoscopy. We'd been fortunate to previously work with the Erasmus group around a modeling study that showed that taking out small polyps does make a difference. But nevertheless, it may just be that if you follow people for longer, that it will still make a difference. So this then at least gives you some thresholds, to probably be able to choose. I'm not going to pick one. That's kind of like up to you, but it gives you like an idea, and it does give you data. Other thresholds, harder to choose and probably evolve over time. Bowel prep, different ones, complete to cecum, complete polyp resection. And one thing that's kind of interesting is that measures that are always met, if you have like 98% of your people meeting the measure, maybe it's not, the juice isn't worth the squeeze in terms of trying to be able to actually like measure that on a regular basis. So the last is how to make it practical. And I would just say that's really just down to probably keeping it simple. Those two diagrams that were kind of like at the beginning. There's lots of different measures, for example, that have been proposed, even just for kind of detection of polyps. The challenge is that some of these are easier to measure than others. And there's also the practicality part. I won't get into all of the practicality parts, but post-colonoscopy colorectal cancer rate is probably imprecise. There just aren't enough of them to identify differences between people. Things such as the adenoma miss rate, or the advanced adenoma miss rate, the advanced adenoma detection rate, all of those require more data, like on polyp size or other things. The adenomas per colonoscopy, sometimes it's hard to sort out. A bunch of polyps get put in the same container. The adenoma detection rate is probably the most feasible of those and seems pretty reasonable in terms of a quality metric. In terms of these, of being like relatively easier, I'm not saying it's easy. And the polyp detection rate is concerned because it's gameable, because it doesn't actually require pathology. Just a couple of last slides. The first of all, in terms of simplicity and keeping it simple as possible, this was published this year in Gastroenterology, that the overall ADR in terms of the relationships across quartiles is really similar to screening colonoscopy, and it's easier to calculate. You don't actually have to assess the indication of the colonoscopy. You just have to know that a colonoscopy was done and what the pathology was. And you can see these all track along regardless of what the indication was for the colonoscopy. And using all colonoscopies, it kind of budges it up or down like a few points, but it's not going to be moving you, like from a 25 to a 35. There's another figure with this that I won't show that we actually compared whether people who were in the lowest quartile stayed in the lowest quartile with these different measures, and the answer was pretty much yes. So, next steps, really kind of create a simple short list. What are the things that actually seem to be able to meet these criteria that are measurable? You actually can find that they're associated an outcome to set to a threshold, they're modifiable, and they're practical to be able to measure. Thanks so much, and look forward to your recommendations and discussions, and realize that there's a lot of quality guidelines that are, that are out there, and really appreciate all the effort that goes into those for improving our exams. Thank you.
Next speaker will be Dr. Antoni Castells from Barcelona, Spain, who will talk on territorial equity in colonoscopy quality improvement in the national screening program. He will have to leave immediately to the airport, so please, we will allow just one immediate answer after his talk. Thank you.
Thank you so much for inviting me to share our experience in one topic that we are really concerned. I don't know, maybe it's the same in your country, that is about, let me say in general terms, if we are providing the best healthcare to everyone, regardless the way, the place where they are living. I mean, we are talking about territorial equity. As you probably know, Catalonia is a small country located in the northeast of Spain with a surface of almost 30,000 square kilometers, with a population of 8 million people. And with, although it's a very wealthy area, there is an heterogeneous distribution of it. I mean that there are a demography that is located in some places in rural or urban areas. We have a quite high unemployment rate, and also the immigration is quite high in the last few years. In the Catalan Society of Gastroenterology, we were concerned about this heterogeneous distribution of our country could be translated in an equal attendance to the people that are suffering digestive diseases. That is the reason in 2017 we launched a strategic plan to promote territorial equity in attending patients with digestive diseases. We select many indicators. The one that I'm going to talk today is the first one. Don't worry, I'm not going to talk about liver transplant or GI bleeding in this symposium. We choose adenoma detection rate, as my colleague Dr. Carly mentioned before, as a single quality indicator of colonoscopy, because you want to evaluate if the quality of colonoscopy is identical all over our region. We select adenoma detection rate because also we have the opportunity to correlate this figure with the one that we obtain in FIT-based screening. That is a paper that we published with our chair, Dr. Kodbyen, many years ago, using the colon prep database, that we could correlate that the 20% figure in colonoscopy-based screening is equivalent to 45% adenoma detection rate in FIT-based screening programs. And this figure is incorporated to the Catalan colorectal cancer screening program as a quality indicator from the beginning. So the aim of this modest presentation is to evaluate if there were differences in the adenoma detection rate among endoscopy units participating in our colorectal cancer screening program. Just to remind you a little bit our program, we are using FIT, actually with a cutoff of 20 microgram of hemoglobin per gram of feces, targeting men and women aged between 50 and 69. We are exploring at the moment to go up to 74, but the data that I'm going to provide is in this range. People are invited to go to the pharmacy or primary care center to pick up and deliver the FIT test.
and those individuals with a positive test are called for an interview to the hospital in an outpatient clinic based with a nurse that is attending these people, explaining the meaning of a positive test and indicating colonoscopy that is performed in the hospital. The analysis that I am presenting evaluate the period of 2 years between 2018 and 19. We evaluated 40 endoscopy units that are distributed in 7 health regions that encompass about almost more than 30,000 colonoscopy that have been evaluated for this analysis. You use the database of the program. I mean that we don't need to collect specifically because we are taking care of our database. And you use the common ADR definition, number of colonoscopy with one or more adenoma divided by the number of colonoscopy performed by each endoscopist participating in the program. And we calculate the adenoma detection rate per endoscopy unit and health region, calculating the mean of respective adenoma detection rate of all evaluated endoscopies. We perform sensitive analysis too. One is excluding colonoscopy with poor bowel preparation, and the second limiting the analysis to endoscopies that are performing more than 30 colonoscopy in order to ensure the robustness of the results. And we calculate the variability between endoscopy unit using logistic regression. And that's the results. When we look at the adenoma detection rate, the average in each health region, you can see that it is quite high, 55%, all of them above the 40% threshold that we use. And when we analyze the data by endoscopy unit, again, all endoscopy units are above the 40% reference threshold, even though you can see here that the confidence interval of some of them are below this line. And that is the same that happens when we calculate variability among endoscopy units. You can see here some of them that are depicted in red that are underperforming with respect to the average of the rest of endoscopy units. And these results were consistent when we performed the both sensitive analysis that I mentioned before. So, in summary, it seems that the quality of colonoscopy measured by the ADR in the Catalan screening programs is satisfactory. Let me say it's quite well. All evaluated endoscopy units has a mean adenoma detection rate above the threshold of reference, 40%, thus suggesting territorial equity with respect to the quality of colonoscopy. There is variability among endoscopy units regarding this mean ADR, and that means that some of them are significantly underperforming. And finally, probably the most important, these results underpin the relevance of monitoring quality KPIs in population-based organized screening programs. Thank you very much for your attention.
Do you have any questions for the speaker? I just have one question, very simple. Could you evaluate if the characteristics of the population had any impact on the adenoma detection rate?
Well, yes, the characteristics has some influence, but when we perform the logistic regression analysis, we counteract these potential differences. I mean that it seems that even though there could be some differences, the result is quite robust.
Thank you very much. Have a nice day.
Thank you.
So our next presenter is Joop Isbert from the Netherlands, and he will be tackling the question implementation of the PDR alongside the ADR, a dire necessity or superfluous hassle. Thank you.
I'm very happy to be here and to see so many people still at the last session to talk about my hobby, serrated polyps. So I'm very happy to be here. So today I want to discuss whether we should consider the proximal serrated polyp detection rate as quality parameter within our colorectal cancer screening programs. I have no conflicts of interest. So, can't really see. Sorry. So, colonoscopy with polypectomy decreases the risk of colorectal cancer in individual patients. However, colonoscopy is not perfect. If we look at all patients that were diagnosed with colorectal cancer during colonoscopy, as much as 8% of patients had a colonoscopy 6 months to 3 years prior to this diagnosis. This shows the difficulties for colonoscopy to prevent colorectal cancer. So there are several causes of these so-called post-colonoscopy colorectal cancers. A colonoscopy could have been incomplete, and the lesion could have been missed during colonoscopy, could have been incompletely resected, or a cancer could have been rapidly developed. So recent studies showed that the most important reason for a cause of PCCRC is a missed lesion. Therefore, improving colonoscopy quality could help to decrease the incidence of colorectal cancer. So we all know that the ADR is a well-established colonoscopy quality parameter. Endoscopies with a higher ADR have a lower risk to be associated with the occurrence of post-colonoscopy colorectal cancer. I want to show you this data from the Dutch population screening, so fit-based screening, showing that the ADR is also usable in fit-based colorectal screening cohorts. Also in fit-based screening, endoscopies with a higher ADR had a lower risk to be associated with the occurrence of interval-type post-colonoscopy cancer. However, even in endoscopies with the highest ADR, still a significant number of PCCRC occurred. Therefore, there seems to be room for other quality parameters. So what about serrated polyps? So we know that 15 to 30% of colorectal cancers arise from serrated polyps. We also know that serrated polyps are easily missed during colonoscopy. PCCRC share a large subset of PCCRC share clinical and molecular characteristics with serrated polyps. This suggests that a large subset of PCCRCs occur from a serrated polyp. Therefore, improving serrated polyp detection rate might decrease PCCRC incidence. So, and this is already discussed in the previous session, which requirements are needed for a new quality parameter for us to consider it? First of all, I think you need an unbiased measurement tool. It needs to be of added value to the existing parameters. Endoscopists should be able to improve this parameter. And lastly, but not also very important, it should be implementable. So the proximal serrated polyp detection rate was introduced as a quality parameter that is a proxy for the detection rate of all clinically relevant serrated polyps. This seems to be better than the overall serrated polyp detection rate, since hyperplastic polyps and the rectosigmoid are not taken into account. And it also seems to be better than the sessile serrated lesion detection rate, since it's not biased by the difficulty for pathologists to differentiate between hyperplastic polyps and sessile serrated lesions. So we have our unbiased measurement tool, but is it also of value in clinical practice? So to answer this question, we performed the following study, also within the Dutch fit-based colonoscopy screening cohort. PSPDR of all endoscopists was measured of around 400 endoscopists, and the PSPDR and PCCRC incidence was evaluated whether there was an association. In this graph, endoscopists were divided into 5 quintiles based on their PSPDR performance. Endoscopists in the lowest quintile are shown on the left, and endoscopists in the highest quintile of performance are shown on the right. Endoscopists in the lowest quintile were used as reference, and all the other groups were compared to this group to see whether there's an association between PSPDR and interval-type PCCRC. So as you can see, endoscopists in the higher quintiles have a lower risk to be associated with interval-type PCCRC. Endoscopists in the highest quintile of performance had a 3 times lower risk to be associated with interval-type PCCRC as compared to endoscopists in the lowest quintile of performance. So PSPDR seems to be of value, but is it also of added value? That is, I think, more important. So to answer this question, we performed the following analysis. Each red dot represents one individual endoscopist, with on the horizontal axis it's the ADR, and on the vertical axis the PSPDR. I'm happy to see that each endoscopist had an ADR above 40%, as I can see now, so that's good if we look at the previous presentation. So what we did in this study is we divided the endoscopists in 4 groups. On the right upper quadrant, endoscopists with a high ADR and a high PSPDR are shown, and those were compared to the other groups to see whether there's an association with interval-type PCCRC occurrence. So this is the reference group, and as you can see, endoscopists that had a high ADR but had low PSPDR at a higher risk to be associated with interval-type PCCRCs. This also accounted for endoscopists with a high PSPDR but a low ADR, endoscopists with and low ADR as well as a low PSPDR had the highest risk to be associated with interval type PCCRC. So I think you can say that PSPDR is of added value alongside the ADR. So these results were validated by a study performed with, from the Austrian cohort. I think you were one of the authors on the paper, so good to be next to you. So what they did, they tried to associate PSPDR with PCCRC mortality. And what they saw that indeed increased PSPDR was associated with a lower risk of PCCRC death. So not incidence, but death. So this validates the results from our study that PSPDR seems to be of added value. So we've got a measurement that's unbiased, that's of added value, but can endoscopists also improve their PSPDR? So to answer this question, we performed the following study that's not yet published. It was a randomized control trial in which half of endoscopists were offered an e-learning of about 1 hour regarding serrated polyp detection. These were 60 endoscopists in one group and 60 endoscopists in the other group. All endoscopists were followed up for 1.5 years. And as you see, after 1.5 years, endoscopists that were offered the training had a significantly higher PSPDR as compared to endoscopists that did not follow the training. So I think you can say that PSPDR can easily be improved by an e-learning of 1 hour. The last question that we have to answer is PSPDR implementable? So is it implementable? I think it's feasible, but it's a bit more tricky, more difficult than the ADR on its own, because you don't only need histology, you also need polyp location. You need to require a system that have both polyp histology and polyp location and combine it to measure your PSPDR. So it's going to be a hurdle, I think, at this moment when you look at the systems that we have in our countries to implement PSPDR, but I think we need to combine our efforts and learn from each other to enable implementation. So then I had take-home messages. I can see them, but you're not, so that's easy. To answer my first question, should we consider PSPDR to be implemented in our screening course? I think yes, we should consider it. But the major hurdle at this moment is adequate registration of serrated polyps. So we have to work on that together, and hopefully in the coming years, we'll see that PSPDR is also implemented in some of the countries. Hopefully for the first in the Netherlands and then the rest second. And as last remark, I just want to say that I hope we also can have international collaboration to bring this field of research further, because we need each other to learn from each other. So thank you very much.
Okay, so welcome to the very last presentation today, which is again on quality of colonoscopy, and there is no conflict of interest. So I don't have to repeat what the previous speakers already have told you, that of course there's convincing evidence that post-colonoscopy colorectal cancers, PCCRCs, occur more often after low versus high quality colonoscopy. This has been shown for several countries, and we also published a study on this demonstrating it for Germany last year. And these publications raise a couple of questions. So the individual person who usually does not know the ADR and PDR of the physician might be concerned, if my gastroenterologist quality is low, am I still protected from CRC? And the decision maker might ask the question, what is the gain in effectiveness if measures ensuring a high quality screening colonoscopy were implemented? The existing studies on this topic do not fully answer these questions because they compared low and high or higher screening quality colonoscopy, but they didn't have a control group, so there was no screen colonoscopy arm. Now, to answer these questions, the ideal study would be an RCT that randomizes people into low-quality screen colonoscopy, high-quality screen colonoscopy, and no screen colonoscopy. But I think you all agree this would be neither ethical nor feasible, and I would not like to participate in such a study. But what you can do is that you emulate such a trial with observational data, and this is actually what we did. So our aim was to emulate a target trial based on observational data, assessing the effectiveness in reducing CRC incidence of a low-quality screening colonoscopy as compared to no screening colonoscopy over 13 years of follow-up. Now, coming to the methods, we used Shepherd, which is a healthcare database covering 20% of the German population. And we included persons aged 55 to 69, so 55 the starting age for screening colonoscopy in Germany. We only included screening-naive people and persons eligible for CRC screening, so persons with a diagnostic colonoscopy in the past were also excluded. And for the screening arms, we had the additional criterion that the baseline physician had to have at least 40 colonoscopies recorded in Shepherd per year, which was a minimum requirement to calculate the polyp detection rate. So we do not have histology, but we could calculate the polyp detection rate. And the cutoff was set at 21.8%, which was a lower quartile of PDRs measured in Shepherd, which has been shown in the prior study. Now, a second slide with methods. The design was a cohort study. We emulated a sequence of trials starting between 2007 to 2013. And so assignment to study arms and check of eligibility was done at baseline for each of these trials. If you have questions about this type of methods, I'm happy to explain it after the meeting. And we followed up the persons regarding CRC and incidence, and calculated cumulative incidence functions based on pooled logistic regression adjusted for baseline covariates. So what were the baseline covariates? We used direct information like age and sex, but also indirect information, proxy information on relevant factors, for example, use of other preventive services, which is an indicator of a preventive behavior, but also lifestyle-related comorbidity. So that's enough with the methods. Let's go to the results. First, the sample size. In the high-quality arm, we could include 142,000 persons. Sorry. In the low-quality arm, we included about 62,000 persons, and the control arm, no screening colonoscopy, included about 1.6 million persons. The mean age was, as expected, about 61 to 62 years across arms, and about half were females. And I decided against now showing you crowded tables with baseline covariates. I just summarize what we have seen in terms of the distribution. So as expected, there was hardly any difference between the screening arms, which is, I think, plausible because persons do not know the quality of the physician, so this is a kind of random process. There were some differences compared to the no screening arm. So as expected, a kind of more healthier behavior. But this was well balanced after confounder adjustment, so there is no need to be concerned regarding confounding in this regard. And now coming to the curves. So the slide shows the adjusted cumulative CRC risk. The black solid line shows the risk in the control arm, the blue dashed line for the low quality arm, and the red dashed line for the high quality arm. So I think two important findings. The first one is kind of good. So low quality screening colonoscopy is effective. That's quite clear. But the other aspect is the relative risk reduction in the low quality arm is 1/3 lower than in the high quality arm. So there is a value in improving quality, definitely. Some further results that are important for interpretation, I think. As I said, the baseline confounders were well balanced. Still, we wanted to be sure that there is no unmeasured confounding. So we also did a negative control analysis using pancreatic cancer as endpoint, and this didn't give any reasons to be concerned also in terms of unmeasured confounding. We also were interested about utilization of surveillance colonoscopy, if it's different between arms. But this was also rather similar in both screening arms. It was 45% in the low quality arm and 49% in the high quality arm. We also varied the type of analysis. What I presented were the results of the intention to treat analysis. We did also a per protocol analysis. This also did not have lead to relevant changes. So these are aspects relevant to the main findings, but I would also like to share with you kind of side results of the study that we found quite interesting. As you know, there is the discussion, and we just heard it again, that yes, that we think that quality is more important regarding lesions in the proximal colon. And if this was the case, you would expect a higher proportion of proximal CRCs among PC CRCs, right? This is why we looked at the site distribution of PC CRCs according to quality of screening colonoscopy, and the results are shown on the slide. On the left-hand side, you see the PC CRCs that occurred within 5 years. The blue is the proportion of distal, and the yellow part the proportion of proximal CRCs. So as you see, there is only a minor difference, also some statistical noise. And when you look at the right-hand side, the PC CRCs after 5 years, you see a almost equal distribution of both, which was unexpected. But I talked also this morning about our current understanding regarding the preventive effect of colonoscopy in the proximal colon and whether it has to be revised. But now I come to the discussion and conclusion of our main findings. So the good news is that low-quality screening colonoscopy is still effective in reducing CRC incidence, but the relative effect of low-quality screening colonoscopy is about 1/3 less than that of a high-quality screening colonoscopy. So it's definitely worthwhile to think of further measures. And now the German gastroenterologists would say, but we already have improved. That's true. So we can see in the data that the polyp detection rate has improved during the past years. But still in 2017, 1/4 of persons with a colonoscopy were still examined by a physician whose PDR was below the cutoff we used here. And now how to improve it, I think it's useful to look at good examples from other countries. And yes, I look to the Netherlands. So we also have a quality insurance program in Germany, but I think the Dutch program has a couple of more components. If I understood correctly, there's also kind of practical evaluation, while in Germany there's just this 200 colonoscopies per year, 10 polypectomies per year, and so on. And but there are also other measures that could be taken, like the nice study by Dekker that he also presented, an online training program that was pretty effective in improving the quality, the indicator ADR. So with this, I would like to thank you for your attention. And yes, I think we will have a discussion right now.
Thank you, Ricky. Now the session is open for discussion.
Monika Ferlic from Vienna. Ulrike, what was your rationale for choosing PDR of 21%, because it corresponds to an ADR of 12%?
So we have chosen it based on the distribution of PDRs in the database we used. So when we determined the PDR of all physicians in the database, this was the lower quartile. And we set this a priori. So this was not decided based on the results, but this was an a priori decision to use the lower quartile as cutoff. We couldn't, for sample size power reasons, we couldn't use different thresholds, so more than 2 groups, so it was dichotomous.
Could you use a higher PDR in the future because you have more and more data?
You mean more groups of more categories?
Yes, or just make it higher, corresponding to the ADR of 25%, so it must be something about 40%.
I'm not sure if we can really, so the PDR we determined here, it's, I would say, a useful measure for the data we used. But I'm not sure if we can really translate it directly based on a kind of factor to the ADR that is calculated based on histology data. So yeah, it's somehow, it is data-driven.
Thank you.
Some great presentations. Thank you. Couple of, well, a comment and a question perhaps. So the comment first of all is about the importance of electronic capture of this data if you want to calculate performance measures. And I think you've demonstrated that a lot can be done, but clearly it's highly challenging unless you have a good electronic system that captures this information. I think we all know that, but let's just stress that. The other question really was for Doug. It's a bit of a comment, really, more than a question, but I really enjoyed your presentation, and you demonstrated that quite a few measures don't have standards, minimum or target standards within them. And you illustrated that with complications, for example. And I think you could probably add in PCCRC if you take it down to an individual level for the reasons that you alluded to, that the confidence intervals are too wide, they're too rare events. But just to point out, really, that we don't have to calculate rates necessarily. It's great if you can, but you need bigger data, bigger figures in order to do that. But actually, for rare events, doing a qualitative review, a root cause analysis, can actually be hugely impactful, and you can learn a lot from that. So I would stress the importance for PCCRCs and for complications. Just doing a case review and reporting on that objectively is often a much better way of dealing with that domain of quality than trying to calculate some rate where you've got a huge confidence intervals. It was a comment, wasn't it, rather than a question, but I don't know if you want to come back on that.
Thanks, and actually, I think it's just such a great point, because we fixate so much oftentimes on these numbers, and the question is how big of an impact. And I mean, a couple of years back, we did something similar where we just said, okay, among our system, why are people dying from colon cancer? You know, we have pretty high screening rates. We just said, why are people dying? And so just to your point, learned so much from doing that audit of like several hundred people that were randomly chosen. And the number one reason, even in a system that has high screening rates, they were unscreened. You know, the second thing was they weren't up to date with screening. Like, so there's people who had never been screened, people who were not up to date. What was like one of the lowest things? Almost no one was that they were not up to date with surveillance. The highest risk thing, although it was only a relatively small proportion, was people who had not followed up after a positive FIT test. That was like the highest like relative risk. But it, just to your point, then it's like, well, where do you put your efforts? Okay, well, the main thing then probably to put your efforts is to try to be able to get people up to date with screening, and it wasn't so much, you know, the interval cancers, especially, you know, et cetera. So again, I think all of these things are important, you know, has been demonstrated, and, you know, for a lot of really careful work from everyone in this room, and I think that's probably one of the reasons why colonoscopy is effective, is because of all of the work of the people who are in, you know, this room and trying to be able to improve the quality. But I think your point is a great one. It's just like understanding why people are still dying and getting from it. You would just learn so much in your own system.
Thank you.
Hi, great lectures, thanks. Jens Axel Nilsen from Oslo, Norway. So regarding performance indicators, we focus a lot on actual the tools to find the lesions, but the aspect of therapy and therapeutic choices is difficult to measure. And what's your take on the rate of surgery of benign lesion, both in the clinical setting and, of course, in the colorectal screening setting? Because that's an important therapeutic choice that affects the individual's survival.
Understand the question?
Yeah, Doug, did you, maybe for you, did you understand the question?
Well, I guess to bounce it off the last question to some extent, like, what proportion of people dying from colon cancer or having post-colonoscopy cancers is it because of a problem with the treatment that they got, such as adequacy of polyp resection? Is that a fair statement?
Yeah, and the choice of therapy actually also affect the individual's survival, because if you choose a therapy that is defined as overtreatment, which is more dangerous for the patient, I think that is also a sort of a performance indicator within the program, the screening program.
Do you want to define an old treatment?
yeah, but
no, I'm serious. Like, what would you say is like one that's outdated versus one that's current era?
I'm sorry, can you just...
Because you said if someone was using kind of like an old, like therapy with an old treatment, I'm just curious of like what would be, I can think of some, but I'm just curious like what would people think of examples for that?
No, what I'm thinking about now, I don't know if I misunderstand you, but the rate of surgery now in the current age, especially for benign lesion, where the current guidelines all really recommend minimal therapeutic interventions because this is much safer statistically. So, but many studies in the last few years have shown that surgery is still widely accepted and used for benign lesions.
Yeah.
And the mortality is around 1%, while mortality for endoscopic treatment is 0.8%. So this is a huge difference. So this is can null out the effect of the screening. And as the studies have shown that this is so much still in use in the States and the Netherlands. So somehow we should make more focus on the actual therapeutics choices for the people in the CRC screening programs. And I don't know how to implement this. That's sort of my question.
So I understand what you're saying, and I think it just kind of like expands what we think of and like where we're putting quality measures in. And so for this, it meets all the things I think that we were talking about before across multiple discussants, though. You know, it's measurable. It has evidence which is behind it. You know, it's associated with important outcomes. You know, it has all of those things. Probably the one thing it doesn't have is there's not like an advocate for it, like someone who's kind of like moving it forward. And I guess, you know, the question then comes like how to be able to do that. You know, I often say within our system, and I suspect it's probably many. You know, there's a person who said, you know, don't think that things can't happen. I'm going to misquote this. You know, just because of a small group of committed people. You know, indeed, that's the only way that anything has ever happened. And this just kind of happens. I think these all happen largely because there ends up being, you know, 1 or 2 or 3 people who start saying, "Hey, should we be doing this?" And then people kind of have to respond to that. And then you have to give a good reason, like why not to. And then, you know, gradually things kind of like move forward. I think that's the case with almost all the quality things, but I would completely concur with you. This seems an important thing to be able to, you know, to measure and to be able to incorporate into our systems in terms of how we do treatments.
Yeah. Great, thanks.
I don't know if other folks have other...
No, I just wanted to say one thing, that I think what is difficult is to have an unbiased measurement. Because it's, for type of therapy, is interpretation of the individual endoscopist or the individual surgeon, but it's not a hard measure. So I think that's the most difficult to implement it. So all the other things, yes, but the first thing is unbiased measurement. That's not going to happen, I think.
I'm Mircea Manu from Romania. I have a question for the last presentation. Did you provide the results to the colonoscopists who do the colonoscopies? Because from my point of view, or at least in my country, if I say to one colonoscopist, you did a low quality colonoscopy, but it works like that, he will never change the way of thinking and the way of doing the colonoscopy. The question is if the colonoscopists hear about the results and they do low-quality colonoscopy, and although
okay. So
this work.
I understand your question now. I think so we didn't publish these results yet, so they are this moment submitted. And yes, we are excited to see the reaction, but I'm not sure if they will change. But we hope that this will maybe prompt politicians to change something that has disappeared. We had a feedback mechanism. So we had a feedback that gastroenterologists or who are doing colonoscopies were told their ADR based on data that are collected in the screening colonoscopy registry. And somehow this has been, this documentation is no longer, does not exist anymore. And we hope that this will come back then, so that this feedback mechanism, I think this is quite useful for the individual physicians. And we also hope that we can convince those people from the gastroenterology associations to initiate, for example, these online trainings or whatever. So
Yeah, I maybe not as pessimistic as you. I think there could be changes, but we will see.
Thank you. Thank you very much.
Of the last question?
Yeah, I was just, it was a curiosity question about Kevin Selby from Lausanne, that one of the striking things with ADR and the colonoscopy measures in the review we did is it was really the only one in all the cancers where just higher was better. It was just like more. And so I was just curious if at this table, if you guys think there should also be maybe, now that with the video assistance and these things, should there also be a ceiling for adenoma detection rate, or do you think anybody does too much?
I don't know. I don't think it works that way. So you're not going to resect a polyp that you find because you're on your ceiling of performance. How would that work? Right? So it's a maximum ADR of one person, and you're doing a colonoscopy in an individual patient, and you find an adenoma in this individual patient, and you're not allowed to resect it because you're on your ceiling of adenoma detection. It's an interesting thought, but I don't think it's going to work for clinic.
I think you're alluding to over-diagnosis and over-treatment, aren't you? Yeah. And I think there is a risk there. It's unquantifiable, perhaps, and the evidence that we have seems to suggest the more you remove, the more good you do. But undoubtedly, the majority of the polyps that we remove actually weren't going to progress to cancers. So we have to be mindful that we are dealing with over-diagnosis and over-treatment here. I think the get-out that we have is that diagnosing and treating a small polyp, the risk of that is so small. The risk of polypectomy really only increases when you come to more advanced lesions, and of course then the risk of the advanced lesion is greater. So thankfully we've got this proportionality of risk-benefit. But I think it is a genuine concern, and particularly with AI, maybe we will start to move into territory where we're finding so many that actually we may possibly start to have a disconnect between increasing adenoma detection rate and reducing PC-CRC rate. It's feasible.
Thank you, Mark. This is the last question. Thanks to the speakers for their speaks. And now Evelien is going to close the session.
Thank you so much. So to me, the honor to close today, of course, on behalf of Michael as well. I have some last remarks. There's, I can't read it actually, because there's another slide here and there, so that's interesting. Anyways, we have a survey after this, which we always like you to do, because it helps us in creating the next meetings again, trying to always improve. We need your help. Again, also for submitting your topics, which really has made our work today of Michael and me very easy, because those were your proposals, really. We just have to mingle them a little bit. But this is the way to put it forward. Michael already has stressed this. The same for chairs. We really like people that are very well known to help us out as a chair, but definitely also younger people trying to get acquainted to jobs like chairing and doing the research and working in this field. So please also let us know if you are such a person and would like to take such a role another time. We will be present at APDW, I already said, in Bangkok. We have a separate WEO meeting as well. But the plenary big day will be connected to DDW again, this time in Washington, D.C. And it's again on the Friday before the meeting. So same as always, I would say. Next slide, please, or shall I do it? So feel free also to suggest colleagues. This committee is open to anyone. So if you know somebody interested, please sign up or let them sign up. The call of topics is going to be in January, and let us know if you want to be involved, as I said. And then, of course, last but not least, I would like to thank the chairs for today. They did a great job trying to discuss and to improve the field of screening. I would like to thank the organizing secretariat, especially Ayana and Ruth, as always, the technicians. And then, of course, last but definitely not least, again, the sponsors, because, again, without them, we couldn't organize such meetings and trying to improve the field. And the sponsors are here. It's Evelien, it's ICON, it's MAST, it's Sentinel, and it's SysMex. So thanks again. We hope to count on you next time again. And now I hope you all join us for drinks, at least one with us. We go out of the room to the right, very near, and join us to say santé. Thank you very much.